नॉइज इफेक्ट कैसे बन जाती है वो तो उसका सबसे
पहले
पहले
No?
Hello, hello. Hello. सेम सिस्टम किया है ना, सेम सिस्टम की मेरे माइक्रोफोन आ गई।
starting from the middle of the bone, as far as my loop can go. Okay. And then I am dipping.
हेलो, अभी आ रही है आवाज? इधर से लूज था।
The loop is entirely submerged. That is it. Okay. As I come towards my predetermined endpoint, I will make the ship more and more superficial by taking my hand down. Before the loop comes in the sheet, the entire chip is off. Can you see this?
Yes.
And it is a canoe shaped chip. Can you see this?
So the second moment is pushing back the chip into the
No. So the chip goes. If irrigation is going on properly, so it will go on its own. So we'll learn this at 6 o'clock. And now if I have to take a thin chip, I will submerge my loop lesser. Okay. So this is how I control the depth of my resection, and before in front of my eyes only I will make it superficial. As I make it superficial, the chip gets detached. Okay.
So we should stop cutting before
Yeah, you should take it very slow, make a very slow cuts, and before this loop comes towards you, you have to make it superficial like this. Then it goes. Okay. So just try doing that. Focus on that. And your chip detaches in front of your eyes. Okay. If you are able to do it at 6 o'clock, next you can do it at 9 o'clock. So each one will take 2 chips, one at 6 o'clock, one at 9 or 11 o'clock, any other angle. Okay.
Where should be our left hand?
So your left hand should be generally there should be at the pubis. It should be touching the pubis and somewhere on your instrument, so that the instrument doesn't slip, or whenever it slips, you come to know, you have some sense. So in the beginning, it is a good idea that you have your hand on the patient's body and this together somewhere. But later, once you are expert, then slowly you don't feel the need for that. But in the beginning, it is good to have.
Then we have to put the camera.
Camera is self-aligning. Self-aligning. No, you don't have to do anything on the camera.
Like normal camera, what you have, it's a bit bulky. So that you have to hold. But this is actually different type of camera. So
this can be free or it can be locked. It will be, if it is free in this phase, then as we rotate, it will come automatically.
So this is not rotating.
Okay.
What camera we have that rotates.
In that we have to reorient it. Here you don't have to reorient. Okay, just focus on taking the chip. Each one of you 2 chips. Okay, and then we will move to the next module. We have only 1 hour for both the places, covering all of you. So give time to others also. I think we can get divided, or we'll talk of resection plan after taking the chip. We'll just, because resection cannot be completed, we just have to talk about it.
I think that we can have this what difficulties they have at each one will be exposed to different type of.
So you are taking an extended cut.
Yes.
You are not taking a fixed cut. No, you have to stay where you are. Don't keep on pulling. Okay. So that is what we are focusing on. Do not take extended cut. Just show me how you will take a cut with a fixed ending, and the chip should fly off in front of your eyes. That is all. You have to take it mechanically. But be very slow. See, I am asking you to zoom into the process of taking one chip. Okay, that is what we are focusing on. Just take one proper chip. almost. Okay. So you are saying that थोड़ा सा difficulty है ना?
So sometimes we notice that even if we try to become superficial towards the end of one taking a single chip, it will still not disconnect completely.
कभी के
So
लिए ठीक है, अभी हम इस पे वो अब हो जाती है तो फिर मैकेनिकली लेके जानी पड़ेगी. But the number of times that you have to detach it mechanically in your resection, if that is 60% now, it should decrease to 5%, 10%.
but so shouldn't we take it completely like to the end of your movement? Then only then it cuts up properly. Like it disconnects properly when we totally take it, they complete the action.
No.
Get the loop.
We are mistaken by thinking that when the loop comes inside the sheath, then it becomes already thin on itself and it gets detached. That is not the thing. You are coming with a burning loop inside, you will be harming your camera. Okay, so you have to, the burning should stop outside of the sheath. Do the same, take one more, have it thicker and then have it thicker throughout the length and then make it superficial at the end. Make it superficial. No, you did it with a jerk in the end. Make it. Don't be hasty anywhere in the process. Try to understand whatever I am saying. Try to understand whatever I am saying. Okay. Yes, take another one. No, you have stopped. Make it superficial. No, you have to make it superficial by dipping it. Dipping will be dipping सिर्फ तुम्हारे एंगल पे होगी ना, मतलब 6 o'clock पे dipping होगी, but towards the, देखो ये आया उसी डेप्थ पे चल रहा हूँ, कहीं पर कम नहीं हुआ, पूरी फुल थिक चिप चल रही है. अब बिल्कुल पास आ गया, अब यहाँ पर मैंने इसको ऐसे कर दिया टुवर्ड्स द लिवर. एज आई डू इट गोज. नो, यहाँ पर वो डिपिंग होगा बट यहाँ पर वो ऐसे होगा और ऊपर से हम करेंगे तो वो ऐसे होगा, है ना. टुवर्ड्स द ल्यूमेन हम उसको लेकर जाएंगे ऐसे. No, you are moving this. You don't have to move this. So go at any other angle. You have taken your 2 chips anyways. So we can do it the same thing on the other module.
You're rotating this to some angle and this to cumulative it is what 9 o'clock.
Yes.
Won't be able to enter. Fixing sir. So camera should be fixed. So there is no further. ये move कर रहा है तो just hold it. If it moving then you have to hold it.
Yeah. That's, you have to focus more on this portion towards the end. Yes, be conscious. Yes, it is mandatory. When we think that mechanically जब हमारा loop अंदर आ जाएगा तो वो already उससे नहीं करना है ना. बर्निंग लूप को बाहर ही बंद कर देना, उसमें चिप डिटैच हो जानी चाहिए.
One of our sir told to make it superficial, but I said no need anyway. You cut it, it will be enough.
So anyway, this is what we have been focusing on from the very beginning. That is for the safety of all the instruments also. Okay. And
I think
so and when in this 1 hour, when we get to interact with the 8 or 10 of you, we have time to just, that's why we decided we'll talk of just one chip, so that we can transmit that one chip to you. If you get that, that is the basic unit of resection. You will be able to do everything. You get sensitized even while taking your chip. If आप जाके अपने उस पे करोगे, if you are sensitized to zooming the process of taking a chip in your mind, then also you will improve yourself. But start looking at with this angle, that you have to master one chip.
So sometimes when it gets stuck like this to the loop, what is to be done? Another chip will
Yes, yes. And in bipolar loops, if you keep it in the middle of the bladder cavity and activate it, then it will go up. Were you able to take?
Yes.
No, you can come out. We started from the mid first, huh? So now you stand here. Okay, make it the beginning point, and then very nice. This is what I was talking about. Yes, you can take one more. Exactly. So this is what you have to master at other angles also. It is the easiest at 6 o'clock. So learning at 6 o'clock is easy, but same thing you have to replicate at other angles. You can take one more on any other angle. Yes, you understood the trick. That is what you have to do.
सर मेरे को यहाँ पे शॉक लग रहा है, that is a bad sign.
You नहीं तुम्हें glove पहनने चाहिए थे.
अच्छा, that's the only. No, and there is something called as electric. I mean shock लगेगा because this is not a true bipolar.
This is not a true bipolar. इसमें current पूरे इससे पूरी sheet से आता है. You should wear a glove. All of you must wear glove.
Injury will not happen.
Urethral injury can happen with bipolar devices. There are bipolar.
Carl Stores का तो true bipolar है.
Carl Stores का true. We can talk of that. We'll talk about that. कि क्या true bipolar है क्या? All of you know what is a true bipolar, what is a quasi bipolar? You know that? We will just talk of this. We'll go to the other room. There is another model there where it's a actual sausage. So there will be some animal tissue that you will be able to take a few chips in, and then Hemant will talk of the generalized plan of resection. आज हम उस पे चलते हैं. Come, we are here. बल्कि हम इस पे तुम लोग एक एक बार कर लेना. तुम हेमंत पहले बताना है मैं बताऊं? ठीक है. Okay. So see, everywhere it is taught differently, and there are few basic plans of resection, but we should have one plan of resection. जो भी there should be some plan as to what type of gland you are resecting and how you will be completing that. Okay, taking a chip is a different thing, but then how you will be resecting a gland, I will be able to tell you whatever I do it. Okay, so if I differ from what your teachers have told you, then just listen to whatever I am saying. I am not saying that you must follow the same. Okay, this is somehow the prostate. If it has a median lobe, it will look like at the bladder neck. Okay, and this is how it will look like at the very. Okay, so what we will be doing is, first of all, we take from the bladder neck. We mark the bladder neck all around, and before that, if the median lobe is there, we resect the median lobe. Okay, so if this is the and our instrument is, sheath is somewhere here, and loop comes like this. Okay, तो हमारे सामने जो ये है ना, इसको हम एक तरफ से ऐसे 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 करके काटना शुरू करते हैं. Okay, so we make first cut like this, and one cut here, one cut here, 3, 4, whatever, maybe 2, 3 cuts, 4 cuts, but then this gets eroded. Okay, तो एक बार में पूरा इतना portion चला जाएगा. That is how we will be doing it up to the mid fossa, or maybe some people at till the veru, ताकि floor clear हो जाए. अगर लोब ये बहुत बड़ा है, ओवरहैंगिंग है, ओरिफिसेस यहाँ है, तुम्हें दिखी नहीं, तो पहले तुम्हें इसको काट के ऐसे करके थिन बनाना पड़ेगा, so that it becomes thinner like this, है ना, पतला सा बन जाए. Once it becomes thin, you can with a non-active loop, you can simply turn it over and visualize the orifice. So once this is gone, median lobe is gone, you have to do the same small cuts, staying in the middle of the fossa. I am talking of a medium-sized gland. We are not talking of a huge gland here. Medium-sized gland ke liye, staying in the mid fossa, we resect so that neck is marked all around. Once the neck is marked all around and done all around, we don't go in the inside again, and we take it as a landmark. So that becomes our proximal landmark, and veru becomes our distal landmark. And then depends on how big the prostate is, we plan the resection of the rest of the prostate. So in a very big prostate, what I would do is, I would make a groove sitting in covering the veru. I will make a groove here, one cut. So it is one chip like this. If this is veru and this is a loop and this is a tissue, so I will take one chip like this, one chip, and then one more chip, one more chip, one more chip. I will resect this entire, eat out this portion. So it gets divided into sort of 2 parts, and I start seeing the capsule up to here. Once this is done, okay, then I know that I will sit here in the middle of this, and I will start doing like this goes toward, we keep on taking 1, 2, 3, 4, just like this, and each chip gets detached and flies away, and we take 4 chips, reach up to the capsule, and then again come back 1, 2, 3, 4 up to the midline, like this. Okay, so this thing goes, similar thing has to be done on the other side, and then you turn it over and do this, and then lastly comes the tissue near the veru. So whatever tissue will be remaining, so you have to cover the veru and take. Now these will be with predetermined end. Bladder neck was predetermined beginning, and you could once you have gained some experience, you can take extended cuts, start from there and take right up to the veru. When you take extended cuts, there is one point that you have to keep a distance between the loop where it is cutting and your sheath, so that there is some tissue visible in between. So when you are coming back like this, you must visualize your landmark. वेरू दिख गया तो तुम्हारा वो वहीं का, अगर तुम बिल्कुल और काट रहे हो चले आ रहे हो बाहर, तो तुम्हें दिखेगा नहीं कि वेरू कब आया वेरू कब उड़ जाएगा, समझे? So when you start taking extended cuts, you have to take this, that loop or tissue दिख रहा है. Got it? This is an important point. ठीक है, और ऐसे ही वेरू के आसपास का वो रिसेक्ट करना है. That is how you do. So rather than going haphazard, you have to have some plan. Mark out what कोई नेस्बिट वाला फॉलो करता है, कोई किसी का फॉलो करता है, कोई किसी का फॉलो करता है. बड़े ग्लैंड्स के लिए अलग है, छोटे के लिए अलग है. ठीक है हेमंत?
मुझे मतलब रिसेक्शन टेक्निक के लिए आई आल्सो हैव सेम ओपिनियन कि initially you try different things, it is a small size prostate, medium size prostate, large size prostate. But I also started with different techniques. Okay, medium size के लिए I'll use this. Gradually you are adjusted to one technique. Maybe it's Mormire, it's Nesbit's, the lateral technique. But I find very important part is to have a good hemostasis. Initially जब हम median lobe resect कर रहे हैं, so at least you whatever place you have started, at least you won't take capsule and you do a good hemostasis over there. जैसे अगर bladder and you are doing this technique, you are first doing median lobe, तो आप यहाँ पर you go till capsule, मतलब complete it. Don't do a incomplete median lobe and you start a right lateral lobe and then you do a incomplete right lateral lobe. There is some bleeding and then you start a left lateral lobe because you are not able to do right lobe and then you do a left incomplete left lobe. So that is not right. If you are doing median lobe, complete it till capsule at some point. So that is your landmark. You know the bladder neck, that is your one landmark, initial point. Veru is your second landmark, but depth is also important. Capsule is your third landmark. Identify at a place and then you follow. Whatever technique you do, identify the third landmark.
इसमें से वो निकाल दिए क्या sausages?
यहाँ पर आपने क्या sausage define कर लिया, so you will do a
push them in.
7 o'clock.
हाँ, push it in.
अगर इस technique में you are doing, सारी saying you go to capsule. What we do is हम यहाँ तक आ जाते हैं mid तक, and then हमें लगता है कि हो गया, हम यहाँ से नीचे जाएंगे, it will all start reading. You come till capsule.
पूरा पुश करो अंदर, आ गया.
बाकी भी करो.
हाँ तीनों करो.
At some which I do at 2/3 and 1/3. So उसके बीच में क्योंकि मुझे लगता है कि यहाँ पर मुझे यहाँ तक आना पड़ेगा, यहाँ से आने में it's easy because ये थोड़ा पास में.
इसको भी पुश.
So earlier I reached till capsule. तो यहाँ से हम स्टार्ट करते हैं, capsule तक आते हैं, तब नीचे गिर जाता है, ऊपर वाला अपर लोब हो जाएगा, ये दोनों कनेक्ट हो जाएंगे, ये ऊपर हो जाएंगे. That you can do later. ठीक है? And फिर यहाँ से आप नीचे with using full depth of loop you can safely resect because you know this is capsule. नीचे का आपने resect कर लिया, अब
और पुश हो गए.
So you have to have some plan. What common mistake we do initially, we don't have any plan, we just start. हमको पता है किस तरह से आ जाएगा. To start with, मुझे तो पता है my plan is not to complete TURP, my plan is just to do a good median lobe resection. So then my plan is to do a good lateral lobe. But I am satisfied what I have done is complete. The speed of resection may vary.
पानी
उसको ऊपर की तरफ क्लिक कर दीजिए, जो लेफ्ट साइड पे बटन है.
ठीक है भाई, this is a different model where animal tissue is there.
काम करूँगा.
Contact Olympus कह रहा है. फुट स्विच असाइन नहीं है. ओके ठीक है. ओके आई थिंक यू कैन ट्राई ऑन दिस. सॉसेजेस हैं हमारे पास काफी सारे, खाने के लिए भी हैं, जो बचेंगे वो हम खा सकते हैं. You can try your hand on this. See how this model is. This model is from. Wear gloves. Gloves. Wear gloves all of you. Okay. No. कितनी देर बची है? 1 घंटे में हम लोग जब से शुरू हुए थे. हमें आधा घंटा हुआ है अभी.
Briefing के बाद half of the participants can go actually in the other station.
On the other one.
Yes.
So we all have tried our hands on the other one.
Okay.
एक डब्बा हम खराब कर चुके हैं उसका. तो now we'll eat some sausages here. See, make sure that the chip comes off. Okay, each chip you take, it should come off.
This is a incomplete cut.
Yes, like that. ठीक है, बाकी लोग भी ग्लव पहन लो, 1-1 मिनट लगा लो इस पे, तो हम लोग कुछ मशीन्स के बारे में बात कर लें.
Output because it is not connected to that.
Yes, that's what I was looking for. ये एक घर पे जाना तुम लोग, अपना नाम लिख के.
problem is after you are not completely wetting. So last part में you are wetting it. To completely close it. है ना?
So you are taking very superficial chip. So first try to dig in deep, take a thicker chip and make it fly in front of your eyes. You are still depending on the curve. See if there is a bulge anyways. If the tissue is bulging like this, then if your loop sits here, if your sheet sits here and you then automatically it will get detached. You are using that not what I asked you to do by making it more superficial.
So now you are not superficial. That is what, है ना? So मतलब incomplete cuts will be there. Yes. Because you have to follow that technique. You go deep and then you come superficial and it will be disconnected. यहाँ वो natural curve नहीं मिला तो you are not able to
See, everything has an impact. If every time you have to detach it, then mechanical friction will be more, chance of stricture will be more. The time taken will be more. You won't be able to graduate to bigger glands. Okay.
There's a natural curve, तो यहाँ पर it will be detached automatically. But flat में it will be difficult अगर आप you will not follow that technique. Try to do it on a flatter surface. और आगे I mean, the cut was not complete.
ये सब चीजें मिनिमम होनी चाहिए ड्यूरिंग योर रिसेक्शन, है ना? बिल्कुल अच्छा रिसेक्शन तब होता है, एक तो बाहर से हाथ देख के पता पड़ता है कि कैसे वो हो रहा है, और दूसरा जब कॉटरी की आवाज टू टक फिर टक ऐसे लाइक, यू नो, दैट मींस यू आर नॉट वेस्टिंग टाइम बिटवीन द कट्स. I use it.
So which sheet size should we use when you're just doing a scoping?
So it should be 2 French more than your
So
resectoscope.
sir, when you're just doing a scoping first before starting.
Then you don't do
You
OT
do after before introducing your
resectoscope, after scope.
Yes, sir. Yeah. So after scoping, before the resector.
Yeah.
Yes.
So generally total 30 take a cut. Like dilate up to 30 French.
So what is size of your receptor?
अगर तुम 24 से करने वाले हो तो 26 से करने वाले हो तो 28.
So it is 4 French more than what?
Until what point should it, like at what point should we stop introducing the electrode? We are introducing the electrode.
That depends. Like there are two most important part you have to dilate is the distal, basically meatus and meatus distal part of it. So in one book, mother it should be till, you have to introduce it with gravity till it goes in.
The
Yes.
resistance stop.
Yeah.
Yes. You should not take it like male dilator के अंदर तक ले गए तब तो स्फिंक्टर कटेगा.
So
You should
यहाँ
not.
gravity से रुक जाए वहाँ रुक जाए.
आपने थंब से कंट्रोल कर धीरे धीरे जितना वो चला जाए उसको होल्ड जो पेनिस में बंद है, देन यहाँ पर रुक जाता है. Sometimes during the scoping, you know that the canal Yeah, but when you do the scopina, you have this feel. In this patient, it is absolutely necessary to dilate the urethra. There's some introduce scope introduce करने में there's some hiatus and some hiatus there's some difficulty. So in that distal part of the urethra has to be properly dilated.
So how to prevent bladder neck contraction?
How do you prevent bladder neck contraction?
60 degrees cross section.
Where is the risk? Where is the risk? In which patients there is a risk for bladder neck contraction? Smaller gland, bigger gland? Smaller gland. So it has been seen that the risk of bladder neck contracture is more in less than 30 grams gland, and there is some risk even up to 60 grams gland. And very recently there was a study, prospective study, which I came across while preparing for a lecture, complications of TURP. So there I came to know that in that prospective study they proved that combining a TURP along with a TUIP, means after you have done the resection, you do a proper TUIP at 5 and 7, that decreases the risk of developing a bladder neck contracture in glands less than 60.
So there are some issue left to do it like if you complete a TURP.
There is, you in TURP you do not transect the neck fibers. So you have to transect the neck fibers.
So just seeing the fibers. With absolute
Yes,
fibers.
and then take, yes, like a TUIP you have to transect the fibers. So that the in smaller glands क्या होता है ना कि जो टोन देते हैं ब्लड डेट्रोसर के जो लोअर मोस्ट सर्कुलर फाइबर्स हैं वो टोन दे देते हैं ब्लैडर नेक को. सो दे वंस यू हैव रिसेक्टेड द ग्लैंड तो रॉ सरफेसेस हैं और टोन उसकी वापस आ गई, सो ऑल सरफेसेस गेट स्टक, मेक क्रॉस एडिशंस. ओके, सो दैट डिक्रीजेस.
How should the irrigation be, sir?
And this is one part. The other thing is that coagulation उतना ही जहाँ बिल्कुल carpet coagulation avoid करना चाहिए. You should identify bleeders and target them. So targeted coagulation. Then doing your this thing traction. You should not leave traction for very long periods. It should be like 4-5 hours. है ना, 4 hours. 4 hours is generally said. More than 4 hours से ब्लैडर नेक पे नेक्रोसिस होती है और वो बनने का चांस रहता है.
Bladder neck, you should do only focus coagulation. When there is major bleeder, only that. Or you should do everywhere, but at least at bladder neck and liver. Major bleeders we usually are.
So you have seen contractures.
अगर retrospect में जाएंगे तो यार most of the like what मतलब the practice has changed, मतलब smaller prostate if I see ना usually they don't benefit with TURP. जो smaller prostate में actually TURP करते हैं वो लोग वैसे भी इतना मतलब prostate is not the cause, so maybe only blood neck incision is.
वो तो 20 ग्राम से कम में बोलते ही हैं.
हाँ.
पर अभी यही है कि 60 ग्राम से कम के प्रोस्टेट में आप साथ में TURP कंप्लीट करने के बाद गिव प्रॉपर 2 इंसिजंस एट द नेक सो दैट फैट तक विजिबल हो जाए, तो उनके फाइबर्स ही ट्रांसेक्ट हो जाए, टोन ही खत्म हो जाए, वहां पे डिफंक्ट कर दो उसको, क्योंकि वो कॉन्ट्रैक्चर क्रॉस एडिशन जैसे ही टोन आएगी उसकी कैथेटर निकलने के बाद वो क्रॉस एडिशन से बनेगा.
बट जैसे हमने TURP इन 60 ग्राम प्रोस्टेट 55 ग्राम प्रोस्टेट, तो हम लोग तो वैसे भी वी आर टिल कैप्सूल तक हम वैल्यू तक आई गए. तो मतलब ब्लैडर नेक इंसिजन तो इट इज डन बिफोर, मतलब इफ वी आर नॉट डूइंग TURP अगर टर्प करती है तो इट इज एक्चुअली ऑलरेडी डन. वो पूरा मीडियन लोब पे हमारा वी हैव रिसेक्टेड दैट, तो अभी हमारे को कैप्सूल दिखाई दे रहा है.
जब हम TURP करते हैं ना तो हम प्रोस्टेटिक टिश्यू ही निकालते हैं, जबकि TUIP में हम फैट तक जाते हैं.
हाँ,
तो वो कह रहा है कि TURP करने के बाद तुम फैट तक नेक पे जाओ.
तो
ये
है
मुझे
जो लगता है इट शुड बी ओनली द ब्लैडर नेक पार्ट,
ओनली
है ना.
only.
इट शुड नॉट कम टिल वेरू, है ना.
नो नो
वाला पार्ट
ओनली नेक,
सिर्फ ब्लैडर नेक को एक्स्ट्रा ओपन कर देंगे.
ब्लैडर नेक
ये वो
पे टोन खत्म हो जाए वहां
वो
पे.
लास्ट में जो हम थोड़े या तो
यस,
उसे कर लेते हैं या फिर चिप से हम उधर डीपर.
अभी मुझे पता भी नहीं उस पे और स्टडीज है, बट दिस वाज गुड प्रोस्पेक्टिव स्टडी व्हिच आई केम अक्रॉस एंड आई फाउंड इट लॉजिकल, रीजनेबल.
मतलब हम में जैसे कि हम थोड़ा करते भी हैं कि आफ्टर TURP हम ब्लैडर नेक को और वाइड ओपन कर देते हैं.
So inflow and outflow should be like how should we like manage the inflow and outflow? Should we stop at some point or like only after completion of the section should we stop the irrigation and then have empty the bladder? When should we empty the bladder? How should we keep the inflow and outflow?
See, after every stage of resection, we should empty once. So that gives a reassurance, one of the outflow color. The other thing is that there was something inside and that is coming outside. That means you have not perforated anywhere. So that way it is always advisable to. But otherwise it depends on जब तक तुम्हें दिख रहा है उसमें तब तक तुम काट लो फिर उसके बाद खाली कर लो so that.
One thing I do is पता नहीं but if it is like this is the medial lobe है ना तो अगर हम ऐसे काटते जाएंगे तो this is flat तो जो भी आपके chips हैं they will come here because वो इनको जैसे जो chips इधर हैं if it is like this so it will come in your loop मतलब वो आते रहेंगे तो क्या होता है कि I preserve a bit of bladder neck initially और bladder neck मतलब I am shallow in start of my resection and then I go deep मतलब ऐसा आता है like this.
Okay.
So you preserve a bit of bladder neck so that once the chip falls in bladder, it don't come back to the prosthetic portion. So at the end of the section, जब मेरा TURP हो गया, then I do neck properly. Neck तो थोड़ा छोड़ देता हूँ intentionally so that the chip do not come back. So it helps. Somehow मुझे help करता है. It does not come.
Good point. I will try.
So it वो सारे chips एक बार bladder में
पर
डालें.
chip को अंदर जाने में उड़ के अंदर जाने में भी दिक्कत करेगी.
हाँ तो वो पैसे
पुश करना पड़ेगा.
पैसे नहीं जाते. मैं जब I do TURP they don't go पैसे नहीं तभी मैंने बताया. I cut और फिर जब मैं ओपन करता हूँ वो चिप में ऑटो वो एक्शन हो गया
ऑटोमेटिकली डिटैच हो चुकी होती है लेकिन
डिटैच हो जाती है कि मैं उसको मैकेनिकली बस जब मैं वापस मैं एक्टिव वो करता हूँ एक्सटेंड करता हूँ इट गोज बैक फिर सेकंड चिप लेता हूँ इट गोज बैक थर्ड चिप इट गोज बैक.
ओके लेकिन ये जैसे अब तुम नेक पर हो या नेक के जस्ट अंदर हो तब तो तुमने कर दिया लेकिन अगर टुवर्ड्स वेरू हो तब तो तुम्हें हर चिप को या चली जाती है
जनरली चली जाती है जनरली जैसे एक फोर्स होती है ना कि जब ओपन के थोड़ा फोर्स किया तो वो ऊपर से थोड़ा सा शायद पुश जाती है बट आई डोंट फील दैट प्रॉब्लम इनिशियली क्या होता था सारे से वापस प्रोस्थेटिक फोर्स में आ जाते थे तो मुझे एम्प्टी करना पड़ता था जनरली आई नीड टू एम्प्टी ओनली वंस दैट इज एंड ऑफ द प्रोसेस. उससे क्या होता था इनिशियली जब मैं बार-बार एम्प्टी करता था तो फॉर 3-4 मिनट का जब वो डिस्टेंस होता था मुझे विजन नहीं आता टिल दैट टाइम तो ब्लीडर स्टार्ट हो जाते थे. आई एम मोर कंफर्टेबल कि अगर मैं एक ही बार एंड ऑफ द प्रोसीजर एम्प्टी करूं अगर पॉसिबल है कभी-कभी नहीं होता लार्ज प्रोस्टेट में आने लग जाते हैं ऐसा नहीं कि
somehow I feel reassuring कि जो है बीच में खाली कर लो तो भर रहा है तो वापस आ रहा है
डिफरेंट yes आई थिंक डॉक्टर इसमें क्या होता है पेन डॉक्टर उनको somehow एक बार हमारे वर्कशॉप में आई सॉ हिम तो वो he do actually do a bladder neck preserving TURP. So I don't believe bladder neck preserving मेरा वो I don't believe that मुझे but when you do start TURP I think वो bladder neck preservation से चिप्स नहीं आते एंड ऑफ द प्रोसीजर कर दो चाहिए.
तो वेरू के पास वाला जब हमने कर लिया अपना प्लान जैसा किया है उसी कर लिया तो हम पीछे आ गए वेरू के पास हमेशा से थोड़ा टिश्यू है तो सब उसको रिसेक्ट करने में थोड़ा दिक्कत आती है मतलब वो जो पार्ट है वो रिसेक्ट सेम एक्शन से नहीं कर रहा तो लाइक सम पीपल से गो एंगेज टेक शॉर्ट कट्स लाइक इज देयर सम टेक्निक टू डू इट और लाइक
सर बहुत अच्छा पे करता है मैंने तो करते ही जाता है रेक्टम में फिंगर डाल के
देखो एक तो ये है कि जैसे ऐसे तुम अगर बाहर से किसी को करते हुए देख रहे हो तो यू विल नोटिस इफ समबडी इज डूइंग TURP अगर जैसे मैंने ये बताया था ना कि ये ग्लैंड है पूरा तो शीथ को देखो तुम बाहर शीथ ऐसे है ठीक है अगर तुम पूरा प्रोस्टेट अभी है तुम ये यहाँ का पार्ट कर रहे हो तो शीथ विल बी विजिबल लाइक दिस बाहर से है ना व्हेन यू हैव टेकन दिस मच आउट तो फिर तुम्हें ऐसा लगेगा कि शीथ का एंगल एक हो गया और तुम ऐसे कर रहे हो है ना तुम्हें बाहर से दिखाई देगा करने वाले का कि एक एंगल हो गया. जब तुम बिल्कुल ही इसके पास का टिश्यू कर रहे हो तो तुम्हारी शीथ बिल्कुल ऐसे आ जाएगी है ना क्योंकि उसका कर्व ऐसे है. द concavity of once you establish the concavity of the prostatic fossa तो फिर your sheath will be somewhat like this. वेरू को तुम करके ओवरहैंगिंग टिश्यू होता है कभी कभी ओवरहैंगिंग नहीं है तो वेरू को कवर करके तुम छोटा छोटा विजन में लेके छोटे छोटे कट्स ले सकते हो. वेरू को कवर रख के और छोटे छोटे कट्स ले सकते हो. अगर ओवरहैंगिंग है वेरू से बियॉन्ड तो तुम वेरू के डिस्टल आके और उसको मैकेनिकली एक लेवल से वेरू के ऊपर से हल्का सा उठा सकते हो एंड देन एक्टिवेट एक रेट्रोग्रेड कट ले सकते हो। इनिशियली शुरुआत में नहीं लेने चाहिए तुम लोगों को, बट अल्टीमेटली लेने ही पड़ेंगे क्योंकि यू विल एनकाउंटर सच ग्लैंड। सो यू कैन टेक द ओवरहैंगिंग टिश्यू, क्योंकि सारा ओवरहैंगिंग जो भी होगा वो अटैच वहीं वेरू वाले उसी लेवल पे कर रहा होगा। एंड यू कैन देन जस्ट डू दिस। डेप्थ के बारे में अगर वो है तो यू कैन पुट अ फिंगर इन द रेक्टम एंड एस्टैब्लिश डेप्थ में तुम क्या कर रहे हो, यू दैट विल हेल्प यू इन द बिगिनिंग।
We are able to dissect, but detach that chip is a little not as simple as.
If once you start focusing on it ना, so take home message ही यही है, focus on the chip। जितना ज्यादा तुम उस पे टाइम लगा के शुरू ऑफ रिसेक्शन, व्हेन यू स्टार्ट द रिसेक्शन, शुरू की फर्स्ट चिप्स में तुम जरा ध्यान दो अपनी एक एक चिप पर कि कैसे तुम ले रहे हो, है ना। when तो फिर होने
अगर
लगेगा।
आप कंप्लीट चिप लेने की हैबिट है, you will be able to do, and there is a bit of difficulty, ऐसा नहीं, there is a bit of difficulty, but there has to be small chip so that, ठीक है ना, and it has to be complete chip। वही होगा कि अगर आपने कंप्लीट नहीं लिया तो डिटैच कैसे होगा। दूसरी चीज है, जैसे रेक्टम में फिंगर डाल दिया तो एंगल बन जाता है। एक तो डेप्थ ऑफ रिसेक्शन आपको पता जाता है, जैसे समटाइम इट इज डिफिकल्ट टू पुट अ फिंगर इन जो आपका फ्री एंड वाले रेक्टम इन द रेक्टम और एंड जस्ट एलिवेट, तो आपको डेप्थ की वजह से वो एक एंगल बन जाता है रेडियो के ऊपर। तो रिसेक्शन वो कॉन्वेक्सिटी आती है, तो
वो वापस वैसे ही हो जाता है जैसे जैसे कि यहाँ पर।
जैसे आराम से
हाँ, जैसे आप आराम से जो कॉन्वेक्सिटी है, तो अब क्या वो कॉन्केविटी होगी, कॉन्केविटी में जो पार्शियल रिसेक्शन कर ले तो कॉन्केविटी में तो वो उसको शैलो करना, पूरा लूप लेना कभी कभी डिफिकल्ट हो जाता है। तो ये पुट अप फिंगर इन योर करना, थोड़ा सा प्रेशर देंगे तो अगेन वो
जब
कॉन्वेक्सिटी
लूप ऐसा है तब वो जो एक्शन है जिसमें हम सुपरफिशियल हो जाते हैं वो थोड़ा सा डिफिकल्ट हो जाता है कभी कभी।
दैट टाइम यू मे हैव टू स्टैंड एंड डू रिसेक्शन, बिकॉज़ आप ऐसे कर रहे हो बैठे बैठे तो आपके हाथ पे बहुत मुश्किल होता है। तो यू स्टैंड दैट टाइम,
जितना बड़ा ग्लैंड होगा उतना ज्यादा ऐसे हो जाओगे, क्योंकि कॉन्केविटी उतनी
you have to
एस्टैब्लिश है।
stand वेरू के बाद sometimes या many times you have to stand, so these are some maneuvers which help you, तो आपको इजी हो जाता है वो एंगल बनाने में।
तुम लोगों ने फॉर्म भर दिया वो?
ये भी किसी
तुम लोगों के नाम भी बताओ यार, कौन कौन कहाँ से हो? वसंत, where are you from? Andhra Pradesh। I hope you were comfortable with the language।
Santosh from AIMS
AIMS Bhubaneswar। Oh, Prashant is my very dear junior colleague। Huh? You are doing a good job। Manoj also, I am also a Jipmarite, so Prashant, Manoj और एक और भी वहाँ भी ज्वाइन किया किसी ने, थर्ड स्वर्णेंदु ने ज्वाइन किया। यस यस, स्वर्णेंदु तो एम्स में था पहले। अच्छा, ओके ओके।
I am Sanket। I am from Mumbai, but I am doing MCA at KMC Manipal।
ओके, सर के साथ। हो गया तुम्हारा ये अभी चल रहा है KMC मैंगलोर में?
15 साल पहले
कौन है वहाँ पर? अच्छा जी जी, लक्ष्मण, वेरी नाइस पर्सन, जोवियल। एम्स भुवनेश्वर, वेरी नाइस। नहीं, ये अभी KMC मैंगलोर में हो गया। ओके, you give it to me। So I hope this would be of some benefit to you। Huh? You in free time you can practice whenever। Yes, if there are no sausages you have to order some sausages। Which one was the better model, this one or that one? This one?
Actually, sir, I think it's designed properly. That one is better to show how to take a chip।
Yes
This one is better to actually plan as।
yes
This gives idea of a loop that tells
Yeah.
you to like exactly how we said. So the chip, so that is better।
You can add some blood part also, then it will be good.
Last time it was there, you could push some red this thing from syringes, but anyway we understood in the very beginning that we won't be able to teach everybody the whole thing, so okay, we forgot about telling about the machine। and the bipolar technology. So bipolar technology, yes, you are right. There are some loops in which the negative electrode is right there on the loop itself, or there are two loops, one, and then there are the quasi bipolar where the negative electrode is the outer sheath itself. Okay, so the current comes back from the outer sheath, but because it comes back through the entire outer sheath, gets distributed there, so the amount of current is not that much. That is why in quasi bipolar it is very important that there should be no bumps or any cracks, और है ना, कहीं पे बेंट हुआ, कहीं कुछ हुआ, तो वहां पर करंट कंसंट्रेट होगा, है ना. और दूसरा, लुब्रिकेशन तो होना ही चाहिए थ्रू आउट यूरिथ्रा में, बार बार लुब्रिकेट करते रहना चाहिए. एंड डेफिनेटली अगर क्रैक्स या बम्प्स हुए तो वहां पर स्ट्रक्चर बनते हैं. दैट्स व्हाई प्रोबब्ली थ्योरेटिकली बोलते हैं कि इंसिडेंस ऑफ स्ट्रक्चर्स आर मोर इन बाइपोलर, बट ट्रू बाइपोलर में आई डोंट थिंक वो प्रॉब्लम होगा. ट्रू बाइपोलर गायरस था और शायद स्टॉर्स का है, बाकी सारे तो यही हैं.
Please go to lab.
Oh shit. What happened? What happened?
ठीक है leave it बंद कर देते हैं. कुछ यहाँ पर कुछ एरिया था ना, वो गया समथिंग इसके ऊपर था ना कुछ कवर
कवर नहीं,
ये था कवर नहीं. अच्छा
ये नहीं, ये लगा था, नहीं लगा नहीं, ये नहीं लगा, नहीं ये नहीं गया.
ये लूप तो नहीं कर गई ना, लूप की बात.
हेमंत, कुछ हमें मॉडिफाई करना है पूरे उसमें या
बेसिक चीज है.
इतनी देर में बस यही कर सकते हैं, नहीं तो सब लोग अलग अलग लेवल पे आते हैं. तो इनिशियल फ्यू, उसके बाद हम पहले सोचते थे कि 1 घंटे में पूरा TURP सिखा देंगे, लेकिन
चलो ट्रॉली लेके जाते हैं.
Manipal. So all of you are doing your residency? Okay, all of you know about RIRS or you need to know about RIRS? You have any, first of all, Just tell me what you want to know and what you have done. Like you have finished your outer the module outside.
Yes, sir.
RIRS thing you are not finished. Okay, fine. So just let me know that how much you know about RIRS and what are your questions. See, doing this moment and that moment, I think I will teach you very nicely. Don't worry about it. Is it on right now? Okay, fine. So just tell me first of all that what you want to know about RIRS. Any questions you have in your mind? I'm sure that you have not done RIRS. So that's the reason I'm asking you that what you want to know as RIRS. Supposing if you want to do start RIRS, what do you want to know?
Versus direction, sir. How does the scope move?
Okay.
Settings of this.
Settings of
Laser, how it works.
laser. Okay.
Basically, the movement and how to access the lower.
Perfect.
things.
Similar. But the access.
Access.
The movement and aftercare.
Good. Good. Let's okay. I'll just explain you about everything you asked me. Okay, so first of all, you have to understand that right now we have got a reusable, flexible scope in our hand. This is P7 from Olympus. Okay, and right now in India, I think we have got Karl Stoves, which is FlexX 2S, which is available. This is also a reusable scope. These are the flexible scope, fiber optic flexible scopes. Other than these scopes, we have got a digital scopes, which are URF V3 from Olympus and FlexXC from Karl Stoves, and also you got a Cobra Vision from Wolf. The diameter of this scope is 7.5 French. The tip, they say that it is bevel tip, or this is a bullet tip. So this is specifically designed for the access, and which is near is 4.5 French or 5 French, if I'm not wrong. And this is 7.5 French in diameter. The other scope is also 7.5 French in diameter. These are the narrowest scopes available in the world market. Nothing smaller than this is available at this moment. Okay. It has got three components. One is accessory channel, which is 3.6 French in size, so that it will accommodate any instrument which is up to 3 French in size. By and large, the another function of the accessory channel is the irrigation. So the fluid also passes through it. So when there is no instrument in the accessory channel, that time you are in a position to produce a 270-degree deflection on either side. Okay. But when the moment you put any accessory inside, it will hamper the deflection depending upon the size of the accessory. So normally it is recommended that if you have an accessory, which is supposing a basket, if it is 1.9 French, so still you have got a lot of space for the water to go in, and that will affect the irrigation minimum, the irrigation as well as the deflection minimum. But if you supposing put a 2.4 French basket, in that case, that will affect the deflection. So instead of 270-degree deflection, we'll get 240 or 250-degree deflection. Okay, so for the lower pole stone, you have to use accessory which is very smaller in diameter. So 200 micron fiber, because that's the smallest available with the for holmium laser, right? Or 1.9 French basket you have to use, so that it will allow your deflection, perfect deflection. Okay. The another important component in this is there are two deflection wires which are responsible for the deflection. Deflection is here you can, this is deflection lever. So if you are deflecting, it goes down. If you are deflecting up, it goes up. So this is an American model where down is down and up is up. There is another model which is a European model where it is reverse. Right? So whenever you order any scope, you have to understand that you tell these guys that I want American model or European model. Okay, otherwise sometimes you will be in soup. The moment it is delivered to you, probably they will not take it back. So you have to understand that. So then it has got a fiber optic bundles. The bundles are two types, optical bundle and the light bundles. The light bundle carries light, and there are optical bundles carries the image. Right? So anything can go wrong with any component out of these four. That's how you have to take care, you have to understand this, that these are the components, so that you can take care of these components while you are using it, so that it increases the life of the scope. Okay. Okay, fine. So here you can see that in this scope, there is a notch at the 12 o'clock position. Okay. And this notch has slightly beveled on one side. So this is the Olympus scope where you got a notch at the top which is beveled on the one side. In case of stores, similar notch is there, but it is straight. So without looking at the make of this scope, you can say that this is, when you are watching some video, you can say this is Olympus scope or a store scope. And the purpose of this scope is that it will suggest that what kind of deflection. So when you it is suggesting that if you deflect down, it will go down. Okay. Fine. Now, the movements you do during the RIRS, which is most important, that how to go to middle calyx or a lower calyx, that is what is the question. Okay. So basically, you are doing 4 type of movements while doing RIRS. With the left hand, you do 2. With the right hand, you do 2. So with the left hand, you are going in and out, back and forth movement. And second is the twisting movement. You can twist the tip of the scope. Can you appreciate that? There is a minimum twist. Because this is Olympus scope, the shaft is slightly rigid. That's why that is not very appreciable. Suppose if you are using a Flex X2 from Carlstos, probably if you rotate, you will get more movement. But these movements are not very much in use. And the more you do, they're likely to break the fibers within. So this is a limited, it should be used in a limited number of cases, not in every case. And you don't require to do that. Now, the right hand is doing a main job. So one is a deflection. So that is one movement you are doing with the right hand. And another is a deflection of the tip of the scope. With your right hand, you are doing a deflection of the tip of the scope. Why do you need this? Because now this is a left kidney. Come here, come here. This is left kidney, this is right kidney, okay? My scope is here. Now the middle calyx is here. So middle calyx comes from the lateral side. So supposing my right kidney, my middle calyx is here. Okay, the pelvis is here. Similarly, left kidney, my middle calyx is here, the pelvis is here. Okay. So when my scope is here, I have to deflect the tip of the scope if I'm working on a left kidney like this, so that it can see the middle calyx. Understood? Now, how to reach that? This is the most important part, because most of people do not understand how to deflect the tip. So middle calyxial entry and the lower calyxial entry becomes slightly difficult. Upper calyx is not a problem, because usually once the scope is on this, you are straight. So with the left hand, you can push in and out, unless and until the upper calyx is also very badly located. But in a situation like this, your scope is here, you push it and you are going into the upper calyx. But pushing here is a difficult job. So how to do that? So that is the 4th movement, what you are doing with the right hand. So with the right hand, supposing if I want to go here now, I have to deflect the tip. So what I'll do is I'll rotate it. Can you see that?
It reflects in the opposite direction.
It reflects in the opposite direction. So what is happening? The movement is happening at the palm, and then my palm is going in. Isn't it? It was at this position. Now I'm rotating my palm in. So this is known as a palm in movement. Supposing I am operating on the right side now. My scope is here. My tip has to go here. What I will do? Palm out. Okay. Very simple. Most of people, when we learned RIRS way back in 2007, we were taught by some company people, because there were no teachers. Hardly anybody was doing RIRS in the country at that time. And those who were doing, they were not doing in a proper manner, and there were no training courses also. So to go here, what we were told is that you keep the scope straight and rotate it like this. But it doesn't happen in the body, you know. It is very difficult. Now, if I want to rotate here, it's possible because there is a lot of space here. But if there is a tissue here, how I'm going to deflect it here? So we are finding it extremely difficult. And then what is happening now? Look at my shoulder. I'm putting a lot of stress on my shoulder. Here, here, and here. Okay. So now once we have understood that For deflection, you gently rotate this. Now look at my shoulder. I have no stress strain anywhere. Okay, and now once here, I slightly withdraw and deflect. I go into the lower calyx.
Yeah.
Simple.
So here we don't have any room for the twisting of this.
I am not doing anything.
When does twisting help? With that?
Twisting helps when supposing you are in the lower calyx. Now you are in the lower calyx majority, or in the middle calyx where the calyx is not always like this. The stone can be here also. So in that case, now if I am seeing the stone, now with my this tip, I have done enough of rotation. Now if I'm seeing the stone also, my laser fiber is protruding, but sometimes you are unable to focus your laser fiber over the stone. That time you slightly twist like this and then finish the procedure. Okay, so otherwise normally it is not needed. Once you are experienced enough, in my practice, I hardly do it. Very, very rarely, once in a year or twice in a year, I need to do it. But that all depends on your experience to reach to the, but if you understand this movement, I think most of the job is done. And then you practice, and I think you make yourself correct, right?
So this remains standard in the American and the European version.
It is same. The American and it has got relevance only in the up and down. So this is known as a this is known as a palm in palm out method described by Professor Oliver Traction. Okay. Now Michael Grasso, the person who actually had a lot of role to play in the invention of this technology with Dr. Begley. So he says that think opposite. So if you want to go out, your movement, the wrist movement has to be in. If you want to go out here, opposite side. Just think opposite. Like a laparoscopy. Laparoscopy में अगर आपको ऊपर स्क्रीन में ऊपर देखना है आप क्या करते हो? स्कोप को नीचे करते हो. साइड में देखना है तो आप इसको इधर ले जाते हो तो इधर देखते हो. The same thing applies. So the think opposite. So this is Dr. Michael Grasso says, and what I say is that go towards the midline. Forget about palm in, palm out. Just go towards the midline of the body. So now this is the midline of the patient. This is the left side. If I want to go here, go towards the midline. My palm is facing midline. Going towards the my palm is going towards the midline because this is the midline. So what I'm doing is this. Now if I want to go here, I'm rotating this because my palm is going towards the midline. You understand that? This is just for the understanding. Maybe after you do 20, 30, 40 cases, forget about palm in and out. You will not even remember what you are doing. And it will be easy for you. Okay. So these are the 4 crucial movements you are doing during RIRS. The 5th movement, sometimes you can assist is the patient's movement. With the respiration, the kidney moves up and down. So when you are operating in the upper calyx, because of the inspiration, the kidney pushes down. And when supposing you are firing the laser or when there is a very small stone, what will happen? You will hit the mucosa. So what you have to tell your anesthesiologist, that's the reason RIRS should be performed under general anesthesia if possible. During COVID time, I have done many cases under spinal anesthesia. It was a special situation. But then the patient is awake, a lot of movements happening, and then you have to tell the patient, okay, so what we did, I normally we have 2 monitors in my hospital. So one I am watching and there is another monitor, patient is watching under spinal anesthesia. I explain him the procedure before him or her, I explain the complete procedure before taking the patient in. And then I tell patient, okay, during the surgery, I will tell that hold your breath. You are seeing the surgery, you are seeing the stone, you are seeing that I am firing the laser also. But when I tell you to hold the breath, you hold the breath. And then I do whatever job I have to do. And then I tell the patient to now breathe in or okay, breathe in, breathe out, whatever. So we instruct the patient. Now in that process, sometimes what happens, you are telling the patient, okay, don't breathe. And you are firing the laser. You forget that you have told the patient to stop breathing. How long he is going to wait? You don't know what is the capacity of the patient, maybe 10 seconds, 15 seconds, 20 seconds. Then suddenly he breathes and you are firing the laser. What will happen? You will touch the mucosa and can lose. So what I do is that this is my method of doing it during the COVID time. I also hold my breath. So I tell patient, okay, hold your breath. I'm also holding my breath. I'm firing. because I know now I cannot hold it more. And my breathing capacity is, my holding capacity is more. I know that it is more than 1.30 seconds that much I can hold. Right. So I tell the patient that I don't want to hold him up to more than 20 seconds. So in 20 seconds only, I just tell the patient, okay, breathe in. I also release my breath. And I also tell the patient, okay, so that's how I know that I am also not telling him to hold the breath for a very long time. Okay. So this is just a modification. The more and more procedures you do, you can devise your own method of doing it. So with respiration, I just show you one thing. You can hold the scope in your hand. So here you can understand. This is a patient under normal general anesthesia, normal breathing. You can see there is a lot of movement happening. So I'm trying to focus the laser fiber of the stone, but stone is moving too much. Now here you can see with the controlled breath under general anesthesia, where anesthesiologist is playing a vital role. I am telling him to just produce a period of short apnea or decrease the tidal volume to 300. Then respiration is very much under control. You can see that now stone is very steady and I can do a fine job because I want to produce a very nice dusting and I don't want to hit the mucosa. Can you appreciate that? These two movements, the same patient, same stone. Okay. So now do the movements which I explained you. See, your scope will be this much in the patient's body. So hold it like now. How to, first of all, how to stand and how to hold the scope. Let me explain you that also. I have described 3 techniques of holding the scope. Dr. Rajiv should talk to you about my book. This is my book. Okay. I think if you want to get a copy, you can tell Intas people, they will give it for free. Okay. So whoever comes for the OPD in your building, I have already talked to Anup. Anup is in your department, right?
Yes.
So I have told Anup that he will also talk to Intas people. So all of you will get the free copy of this. You can go through it. Every single thing you need to know about RIRS, and it is explained very well into this book. Okay. So what you should do is holding the scope. Now there are 3 types of grips. Some people are holding it like this. Now when you do this, there is a lot of pressure here. And when you want to produce palm in and out, there is kind of a locking here. So you are not comfortable. Second is, some people are holding it like this. This is known as a palm grip. Completely you are holding the scope in your palm. You can see that there is hardly any distance between these 2 things. And the third is what I prescribe is finger palm grip, like this. Holding the scope both with the palm and the finger. Now here, because you are in a very comfortable position. So this is one. Secondly, how to stand. Normally, in this book, I have explained you ergonomics. Most important is make yourself comfortable. Because this is me operating in my operation theater. You can see the positioning of the monitor, where to keep laser fiber, trolley, and etc. Normally, when we operate, like if the trolley is like this, right in front of you, it is always preferable. Why we are doing TURP, we normally, I like to keep it because I don't have to twist my neck. Okay. But the anesthesiologist is standing there, right in front of. So you are not comfortable, he is not comfortable. So some people put it over on this side. The entire cart is on this side. So you are operating like this. Again, no problem because you are holding the scope like this. Only thing is that the scope is the trolley is here. If I want to take any instrument from my trolley, I'll have to twist my body like this and take it. That is producing unnecessary stress on my shoulder, my body, my spine. So what I do is that I keep it like this. Now, when I'm operating this way, the patient is this way, and the monitor is here. When I'm operating, I'm resting my left elbow over the left stirrup of the patient here, so that there is no stress here, strain here, and I'm operating. And then if I want to take anything from here, I can pick it up. Okay. So this is what has been described here.
That is for all the procedures, or is it better to keep the trolley or the monitor on the side we are operating? Like when we go for URSL, usually we try to keep the monitor on the side you're operating. Like if I'm operating on the left side, I keep the monitor on the left side, so the twisting movement of the neck doesn't happen.
Even if you are operating on the left side, supposing during the URS, then most of the times you don't need to, most of URS, you don't need to pick up any instrument from your trolley. Here RIRS, sometimes you don't want to take a basket, this and that. So for RIRS, I am comfortable putting it this way. For PC, and see, this is ergonomics is to make yourself comfortable. As you said, you are comfortable this way, fine. Absolutely
Like for the
correct.
left side, if I'm
Whatever
operating
whatever
the-
way you are comfortable, you are right. If you are comfortable this way, but if you need to take the instrument, supposing you are doing URS also, now if you are left operating on the left side, and if you are to want to take any instrument from the trolley, you have to twist your body like this, right? Or you have to tell the sister, okay, give me this, then you are doing it like this. So whatever way you are comfortable, you can do it, but this is how I do it, and I have found it very, very convenient for me. Okay. So holding the scope like this, that is one thing. Then palm in and palm out movement. Okay. So you can now try it outside.
Access sheet we have to.
I'll show you. No, it's okay. Camera is fine. Hold it. Slightly bend it so that you can appreciate the movement. Slightly deflect it down. Oh, okay, fine. Now do it. Slightly deflect it down. Now and keep your thumb there only. You don't take it out. No, deflect it down, dear. Yeah, hold it.
So what size access sheet do you use or recommend? Because we have the 10, we have the 13 as well.
Okay,
10 and
so
12.
yeah, that is again a very good question. I just explain you. So you are getting the movement now. You keep it fixed. Look,
Deflecting it down.
no, deflecting down नहीं. ये deflecting down इसलिए कि मैं थोड़ा आपको ऐसा करेंगे तो आप movement appreciate नहीं कर पाओगे. इसलिए मैं थोड़ा आपको ये just for your comfort I am doing it. Now I am holding the scope like this. Okay, the movement is happening only at my wrist. I am not using my. I am just supporting the scope with my left hand. If I want to go in. And this deflection, you don't have to release it. Keep it. You will be more comfortable doing this movement.
We don't get any secondary deflection, no? So like touching the
Okay.
wall of the pelvis. and then-
No. So normally you don't get it. You have to try to get that secondary deflection. This is the active deflection. Now, if the pelvis is rooming, in that case only, and if you are not unable to reach to the stone, in that case only you use a secondary deflection. So what you will do is, supposing this is the pelvis, okay, I press it like this. I'm getting extra deflection, and that secondary deflection is produced here. Primary deflection is this segment. Secondary deflection, you can see that it is extended beyond it. Okay, but for that you need a roomy pelvis. If it is a very short, small pelvis, you don't get a space. Okay, and now regarding coming back to your question, question about the ureteral access sheath. I normally see this is 7.5 French ureteroscope. So what you need is say 9.5. This is 9.5 by 11 ureteral access sheath. At least there has to be difference of 2 French. Then there is an adequate fluid return also while you are performing the procedure. Fluid return is necessary because you want to decrease the intrapelvic pressure. Okay. So when you are using a digital scope, it is 8.5 French. So it will not go through this 9.5 French. And even if it sometimes you try to, it will not go first of all. But then what you need is at least 10, 12 ureteral access sheath or 11, 13 ureteral access sheath. There has to be difference of 2 French. Now, UROMET 10, 12 ureteral access sheath, which can accommodate both digital as well as this scope. Supposing you are using a ureteral access sheath from BioRaid or Bluening, Indian made, then if you are using a digital scope 8.5 French, sometimes it is difficult to get a good fluid return. It will go, but then it is almost snugging, or it will hamper the movement.
Becomes very
Snugly fit. So that is not a good idea. So because it's not important only to put the scope, you want to have a good fluid return, right? So that's why then you use 11, 13 ureteral access sheath or 12, 14 ureteral access sheath. But my personal preference is use 10 French ureteral access sheath, 10, 12 ureteral access sheath. Now 10, 12 ureteral access sheath is a good compromise. Reason, the average diameter of the ureter is 10 French. Ureter has a different diameter in different places, but if you take the average diameter, and this has been proved by some study that somebody did a IVU for 100 patients, and then they measured the diameter of the ureter, average diameter, and they came to the conclusion that it is 10 French. Now, if it is 10 French, you can comfortably place any equipment which is less than any accessory which is less than 10 French in the ureter. Majority of the patients. Okay, not all. Now, when you are talking about 9.5 French, 11.5 French, basically you are talking about 11.5 French, because it is the outer diameter which is important, because this is 10 French and this is 11 French. It is sometimes difficult, right? But this is the smallest ureteral access sheath and smallest scope available. If you have to reduce the size of this, you have to reduce the size of this also. Understand?
So if you are placing a 13 French access sheet, then 11, 13 set, then do you think that is more traumatic for the ureter?
Very traumatic. In Indian ureter, even putting a 9.5 French new ureteral access sheath is also sometimes difficult. Because in my practice, I don't pre-stent the patient. So I take all the patients are fresh for me. So sometimes putting a 9.5 French ureteral access sheath is also difficult. It's not as easy as it seems. And especially when you are reusing the ureteral access sheath, it's a hell of a job. And majority of the institute, they are reusing the ureteral access sheath. And I think you asked me some question about ureteral access sheath.
Yeah. Do we
Need to use ureteral access sheath or not? Okay. So ureteral access sheath is not mandatory. But do I put ureteral access sheath in majority of my patients? Yes, I am putting in almost 60 to 70% of the patients ureteral access sheath. Why? Because this will facilitate my entry into the upper pelvic LSL system easily, because the ureteral access sheath is in position. Secondly, it will certainly decrease the intrapelvic pressure. Third, when I'm dusting and fragmenting the stone, it's very difficult for me, very easy for me to do the clearance. So the complete clearance I obtain is much better when there is a ureteral access sheath, right? And then sometimes it protects the scope also. So that's the reason I'm using ureteral access sheath in majority of my patients, almost 60 to 70 patients. When the ureter is very narrow, then that time either it's a good idea to put a double chest stent and come out and maybe go next time. Or sometimes I backload my ureteroscope over the guide wire and completely produce a dust. But that is possible when the stone is very small, not very large stone. Because I will take very short time, 20 minutes, 15 minutes for finishing the procedure. So then it is okay not to use ureteral access sheath. But when the stone is large, when you are likely to take more time during the procedure, it's always better to put a ureteral access sheath. Ureteral access sheath, why people are resistant using ureteral access sheath? Because they think that it can produce trauma to the ureter. And there was a paper published by Dr. Traxler in 2015 Journal of Urology. They said that ureteral access sheath, you will find that information also in this book, that he endoscopically classified ureteric injury, the grades. Grade 0, no injury. Grade 1, only mucosal injury. Grade 2, injury to the muscles. Grade 3, perforation. Grade 4, avulsion. These are the 4. Now, so what they did was they used a 12-14 ureteral access sheath. 12-14 new ureteral access sheath in European patients, 2 centers, 367 cases. So then they observed visually, while taking out the ureteral access sheath, you have to take out the ureteral access sheath under vision. Otherwise, how do you know there is a mucosal injury? So ureteral access is placed, use a digital scope, not this scope. Digital scope, vision should be like this. Then under vision remove, I'll just show you one video that whenever I put a ureteral access sheath, I completely take it out under vision. So when you take it out under vision, you will appreciate that there is some kind of a mucosal tear or mucosal, which you normally don't give a damn to it. Okay. But still, they classified it as a mucosal injury. So in their study, 33% of the patient had a mucosal injury. Almost 4 to 7%, exactly I don't remember the number, but 4% of the patients will had a 4 or 8% of the patient had a muscular injury, muscle injury, and 3% of the patient had a perforation. In my practice of now, I think I've done thousands of cases, and I can tell you that I have not seen any perforation while doing RIRS. Mucosal injury, yes, this is possible. But what is the treatment of that mucosal injury? Stenting or ureteric catheter? Nothing. What is the injury? What is the treatment of that mild muscular injury? Stenting. What is the injury of perforation? Stenting. That's all. You avulse the ureter, there is a problem. That's why whenever you begin the flexible ureteroscopy, the first step is to do the assessment of the ureter. That's the reason it is recommended that you do a semi-rigid ureteroscopy. In my practice, I am using a 4.5 French ureteroscope. That's my first step, right? Many people are using 6 French or 8 French ureteroscope. 8 French is too big for a human ureter. It should not be used unless the patient is dilated or stenting has been done. I use 4.5 because I believe that, and for you, because you will be starting your career, I'm telling you that buy one 4.5 French ureteroscope. It is a lifesaver. Most of the people do not realize this because you can directly insert. You don't need to do. I don't do a cystoscopy also. Now, what is the first step of ureteroscopy? Exams don't tell this. Okay, do a cystoscopy. Look at the ureteric orifice. Put a guide wire. Do a dye study. Study the ureter. Put a guide wire. Then do a ureter put a ureter lecture sheet and follow. Right. This is how the standard teaching. In my practice, what I do is that I tell the patient to go to the washroom before I take them in the operation theater, so the bladder is empty. Do a ureteroscopy, 4.5 French, without using a guide wire, straight go into the ureter, assess the ureter. If the scope is gripping the ureter, completely the ureter grips the scope, sorry, the other way around. If the ureter grips the scope, even a 4.5 French scope, it's not a good case. Put a stent and come out. But if it is a cakewalk, like a simple, nice, easy walk into the ureter right up to the pelvis.
In these cases, for how long for the stent and when do we go on again?
Okay, so when you need to put a stent, the recommended thing is to put it at least for 2 weeks. But I have found that 10 days are enough. Okay, 1 second, I phone ले लेता हूँ. हाँ अमी, बोलो. 40, 40, 40, 40, 40. हाँ 50. हाँ. So sorry, where? Okay. 10 days is more than enough. Some patients, in spite of putting the stent for 1 month also, you are not producing enough dilation. So if you are unlucky, then it will not work for you. But otherwise, 10 to 14 days, good time.
But mostly like if he has a mucosal injury or a muscle injury, then is there a difference in the amount of duration of the time?
Keep the stent for a longer time. Mucosal injury, I don't mean most of the, unless if you do the supposing I'll just show you one.
So when do you need the stent? If it's a smooth case, normal.
7 days. Now 7 days.
Okay, 7 days.
I don't want to retain the stent for a very long time.
And if at all there is some injury, we keep it for 4 weeks or 6 weeks.
There is no defined period, but I think 4 weeks are more than enough. 4 weeks are there. There is no straight away recommendation that you have to do it for. So supposing I just show you a small video. So this is my trolley setup. This is how I organize my trolley. On the trolley, there should be minimum instrument. This is a ureteroscope. This is cystoscope. If you want to do it, I don't do it. But supposing somebody wants to do it, you can do that. Cystoscope. Then no other extra instruments, no rigid instruments. This is a scope. This Flex XC, which I am using. So the first step is to do a cystoscopy. Once you do the cystoscopy, study the urethra. Sometimes male urethras are, young men urethras are very bad. The urethra is the bulbous urethra is very petulous kind of thing. And then there is high riding bladder neck. In that case, what you get is a kink in the guide. Once you put a guide wire, there is a kink in the urethra itself. And if you backload the scope, it will backload there only. These are the difficult cases. Young men with a high riding bladder neck. Guide wire, use usually a Teromo guide wire or a sensor guide wire. My personal preference is to use a sensor guide wire because the shaft is rigid. So it will allow backloading. Sensor will slip out of the system. Right? This 4.5 French ureteroscope, which I am using. The idea is to study the urethra, study the ureteric orifice, and study the ureter. Urethra, as I told you, that will give me idea whether I will be in a position to do it or not. Then second is ureteric orifice. Based on my experience, I have classified ureteric orifice into, so this is a ureteroscopy being done. So based on my experience, see, I'm not using any guide wire. Straight away the ureteroscope is inserted. Don't tell it in the exam, okay? But in your practice, you can do it. And many people are doing it. But exam, sometimes you have to be very theoretical, okay? But I'm just telling you the practical point, okay? So now based on my experience, I have classified ureteric orifice as small, medium, or large. This is normally you get when patient is stented. This is very tight ureter. Now I'm going, this is a good ureter. So this will give me idea whether I will be in a position to use 9.5 French ureteral access, no ureteral access, or 10, 12, or 11, 13 ureteral access. So you don't open all the instruments. Depending on your study, you can do it. So assessment of the ureteric orifice. And then you go into the ureter. Once you go into the ureter, you will come to know about the status of the ureter. If there is any accidental stone finding, the stone slips out of the kidney and then they fall into the ureter, you can deal with it. Unless you have done that study, and if you try to push a ureteral access, what will happen? It will traumatize. Okay. So this is what I wanted to say, that 10, 12 is a preference, right? This is just to give you an idea. All these pictures are there in this book. That there has to be a gap of at least 2 French between the scope and the ureteral, inner part of the ureteral access. That will allow good fluid return, and that will decompress the system so that the intrapelvic pressure will also reduce.
So to what stone you do?
Okay, a grade of injury. This is a mucosal injury. This is muscular injury. This is grade 3 perforation. Okay, can you see that? And this is the video of the same patient. Now this I could identify only because I took out the ureteral access sheath under vision. Okay, so under vision ureteral access sheath removal is very, very important. Sometimes dye study we discussed. Okay, so whenever you do dye study as a standard teaching, initially the vision is like this. So wait for at least 1 or 2 minutes, because the density of the contrast and the density of the water is different. So the vision is always turbid like this. But the same patient, you can see now with the vision is improved after 2 minutes. So just wait, just gently flush the fluid, completely drain the system, and the vision will be like this. Okay. Then the putting the once you put the this is just to explain in and out movement. You can see that. Just listen to. Can you see that? So this is the left hand. With the right hand, I can produce a deflection of this is basically used to go into a desired calyx. This is deflection of, you can see the upper calyx and deflection. Now the stone is level of hypoplasm. The another movement which you do with your right hand, which is very, very important movement, is palm in and palm out. Both the movement should happen with the movement of these here. So when I rotate my fist like this, but the tip of my spoon goes on the other side. If I rotate my fist like this, it goes on the other side. Okay. So this is about just to explain you. Okay, and this is how we do the procedure. So this will answer your most of the questions, you know, what you had. Okay, so this is the assessment of the ureter with the 4.5 French ureteroscope. You can see that. Now this ureter seems to be very good. Now what you do is that at that time, if you want to do a dye study, you can do it. If I don't want to, I don't do it. So put a guide wire through it. So and fix the guide wire always here. Most of the people fix it here. Okay, and it will slip out. So always fix the jacket here. That is very, very important, very crucial point. Okay, because if you are putting it here, the teruma will certainly 100% slip out of the system. So use a semi-rigid, the the shaft which is a rigid, so the sensor guide wire is my preference. And now once I do that, sometimes I use a double lumen ureteric catheter. You can see that this is a ureteric catheter with the 2 lumens. So it has a flexible tip and the shaft diameter is 10 French. 45 centimeter is the length. So it serves 3 purposes. One, that you can put because there are 2 lumens, you can put one extra guide wire. So as a safety guide wire you can put, okay, right? That is one thing. Secondly, you can inject the dye. So you can do a dye study, right? And the third important thing is because the shaft diameter is 10 French, it will dilate the ureter. And you can have a feel of the ureter also. You can see that, okay, 10 French, it is not gripping. The ureter is not gripping my double lumen ureteric catheter. I am comfortable putting at least 9.5 or 10 by 12 ureter access sheath. You understand that? So, and then you can do a dye study. You can put another guide wire if you wish as a safety guide wire. Safety guide wire, theoretically, EAU guideline, AUA guideline, you must put. Exam, you must put. Okay, India, not possible. Safety guide wire, most of the patients, extremely difficult. Safety guide wire, one guide wire, working guide wire, over the guide wire, you push the in a non-dilated ureter, most of the patients, it is difficult. Okay, whenever you put ureteral access sheath, always lubricate with the water because it has a hydrophilic coating and that coating stays for the first case. So the next case, this becomes a theoretical procedure. Okay, but we do it always, even if you are 10 times you have used, we try to lubricate it. And then when you insert the ureteral access sheath in the rotating movement, gently, don't push it. Okay, if you feel a grip or if you are feeling resistance, stop. Now you can backload the ureteroscope over the guide wire like this. Okay, so the ureteroscope is being pushed into the kidney. Now you can see the stone.
So you always have to introduce it, backloading it over a guide wire, or you can remove the guide wire and then place, because
fantastic. These are all questions asked to me during all workshops. Everything you will find in this book, but I'll just explain it.
So because at our institute, I've seen that they
So
take
that
out
is,
the guide wire.
yes. This is a very, very important question you asked actually, lady. Here there is a ureteral access sheath. Okay, we are putting ureteral access sheath in the upper ureter. You understand that, right? Did I explain you that? No, but you know it, because if you put your ureteral access sheath here, you won't be able to. Yeah. So your ureteral access sheath is here. Your guide wire is now. Just imagine that your guide wire is here. Now you take out this guide wire, like in your institute. So you are left with this situation. So you can push your scope right up to here. Now supposing, what if the ureter is like this? Your ureter access sheath is here. Then you have to navigate through this entire thing without a guide wire, which is a difficult job, and which is not uncommon also situation. Okay, and then you will struggle a lot. You will try to push, and then you can traumatize. So most important thing is that once the guide wire is in, and this shaft is kind of a semi-rigid or the solid shaft, in that case it will straighten the ureter. So you can backload right up to here. Now you are through. Okay, then produce a dusting. Don't try to take out the stone fragments. Okay.
But if the guide wire is already in there, how do we introduce the laser, sir?
The guide wire comes out.
Guide wire nikal denge na. After
Of course,
point
this is a working guide wire. Over the guide wire, you are reaching up to the stone so that you don't have to. Otherwise, you are losing the battle what you have won actually. So I always say that don't lose the winning battle. Don't lose the winning battle. First, reach to the stone, produce. Oh, Rajiv, आप सिखाओ उनको उनका. So I always tell that don't lose the winning battle. So reach to the stone, finish the job, and it's good. Okay, and if you have put 2 guide wire, safety guide wire, that is additional help in this case, because this working guide wire will come out. So again, what will happen? The ureter will be like this, even if your scope is here. So many times, it may be because of the scope also it will straighten. But sometimes there is a situation like this, right? So in that case, if there is a safety guide wire, it will again keep the ureter straight. Okay, so that you can dust the stone, you can take out the fragments also. Here, taking out the fragment is also going to be difficult. You dust the stone or fragment the stone. Now you are taking it out. You are coming like this. Now again, how do you insert? So you have to struggle. So that is the reason always this question is asked, what you are asking me in my all workshops. She's asking me that why do you need to backload the scope over the guide wire when there is a ureteral exercise in position. But I always say that this much of ureter, why do you want to navigate without a guide wire? What is the problem putting? Why once the guide wire is in, when the ureteral exercise is in, why you are not taking advantage? I have never understood this. I mean, the only reason explanation what they can give or what I can give you for this is that when you are backloading the scope over the guide wire and supposing it is sensor guide wire, the tip is sharp. So sometimes there is a theoretical possible of damaging the scope. Okay. But if you know exactly how to backload it and you keep the scope straight while backloading, nothing happens. Okay.
So do we have to hold the access sheet outside the urethra? Because I've seen some of my faculty, they don't make us hold the access sheet, like fix it in position. I've been doing PCNL. We hold the
I'm holding it with my left hand, with scope as well as the sheet, both. I'm stabilizing it. Because so many times when you are doing that, it will come out. And now what will happen? The worst thing which will happen is that you got the outer sheath in, your sheath has come here now. Okay. Now most of the doctors, they'll push it in. Okay, they will push it in. Now when you are blindly without an obturator, you are pushing some hollow tube in the ureter because there is a tube within tube. Okay, so that will rub against the mucosa and that will can damage. So that people don't understand, and then they, because they are boss, they are experienced. Okay, why not? Then if you want to really do it, okay, take a obturator, put it in, and then do it. What is the problem? See, try to minimize the complication. Always, and ureter is never forgiving. One thing we have to remember that ureter is not a forgiving organ. Okay, and patient will suffer a lot. Stricture, post RIRS stricture. We have seen, in my practice, I have seen only one case, which is come to my notice actually, that patient had a stricture. But so many people are telling me that post RIRS, they are getting a lot of patients from some doctors, they are doing RIRS and they are causing a stricture. So post RIRS, ureteric stricture, the incidence is more in some part or some unexperienced person because they don't know exactly how to do it. Even if you are taking out supposing there is a stone fragment, you are grasping it with the basket. Now what they do, they completely try to pull out without under vision. You have a nice vision. Just try to pull it out under the vision, and then your stone has to be almost flush to your the outer tube like this. But they keep it like this, and then it can cause a trauma. Or they are grabbing a very large fragment. You don't do that. Don't bite more than you can chew.
So, sorry, at all the access sheet comes down. Can we withdraw our scope and then introduce it up, like introduce it?
You can do that, but I think why do you want to do that? Then you take out your scope in case, and then you can maybe. That's an easy way of doing it.
Sir, for what stone model you recommend?
Okay, so now you were asking me about the lower calycial stone. Okay, so this is the lower calycial stone. Once the stone is in the lower calyx, now you have to understand the anatomy of the lower calyx. I'm going too much theoretical, I think, but I think probably it will help you rather than doing all this jugglery that you can do outside also. Okay, is lower calyx. So this is one line drawn and this is another line drawn. It's rather it will come here. So this angle, IP angle, infundibulopelvic angle. This angle is very critical. So whenever we're taking a decision for doing RIRS, especially for the lower stone, you have to understand this. That this part, if this angle is very wide, it's like this, your entry into the lower calyx is easy. If it is like this, sometimes the calyx is here, then angle is here. If it is less than 30 degree, extremely difficult. Don't select it, especially in during the learning part. It is said broadly that if it is more than 90 degree, the job is easy. Less than 90 degree, the job is difficult. Second important thing, infundibular length. If this length is, supposing there are some infundibular like this, if it is too much, then there is a problem. If it is more than 3 centimeter, again RIRS is difficult. and infundibular width. If this 5 mm. So if the infundibular width is more, it is easy. So whenever you are doing the procedure, when you are putting your scope, I mean preoperative IVU or CT scan may give you some information. Sometimes RGP is a better guide than the IVU, right? Because then you can exactly know what it is. Sometimes you are misled by CT picture also. So RGP picture is the best to study the pelvic LISL system. So sometimes we do RGP and then we understand. Okay, once my scope is in, I understand that, okay, this is a good angle, I go in. Now, depending upon the size of the stone. If the size of the stone is less than 1 centimeter, probably I will be in a position to grab the stone and put it into the upper calyx. But if the even if it is less than 1 centimeter, but if it is the infundibulum is like this, what will I do? Will I be able to grab the stone and put it into the? No. In that case, what I have to do is I deflect the tip of the scope in there, put the guide basket, laser, fragment it completely, make 2-3 pieces or 4 pieces, and then take it out, or maybe complete dusting in the lower calyx itself. That is one. If the stone is small, the infundibulum is wide, break it, grab it and put it over in the upper calyx. No problem. Or the stone is very large, even if the infundibulum is very friendly, you cannot grab it. Then break it into few pieces and put it into the upper calyx or middle calyx. Don't say that it is upper calyx, okay? Because upper calyx is not necessarily straight. In a most comfortable position where the scope, the tip of the scope is straight. It could be middle calyx, it could be upper calyx also. Okay. So you grab it. So like in this patient, now you can see that there is a stone. You can see the basket, the stone is basket. The infundibulum is wide enough, you know, it's a large stone. So there are 2 stones. So the one stone, now it should be positioned, is placed here. You can see that here. And the another stone, you can put it over there and then deal it with as if it is a upper ureteric stone. Upper renal calycial stone. Or in this case, the stone is fragmented in situ. And now this is one method which I demonstrate in majority of my workshops, that for the grabbing the stone, you use a basket. Supposing that you don't have a basket, what will you do? So what I do is I puncture the stone. Of course, it takes some experience also. I puncture the stone, drill the stone, and then with my deflection lever and with the laser fiber, I put it into the upper calyx. You understand what I mean to say? So this is how you can see here. You can see.
That is the tip of the laser fiber. So when
Sorry?
you're building it and putting it inside.
Look at this. Oh, sorry.
Building it and putting it inside, does it damage the tip of the laser fiber?
What difference does it make? Even 5 mm is gone, what is the problem? You can always cut it, na? So this, supposing we don't have the basket, you can do it. Sometimes in a private practice, you got only one basket and it's broken. And this will happen not only to you, many people, right? So this you can do in all my workshops, whatever workshops I have done conducted for USI or wherever, people want to see this. I demonstrate this if possible, not always, but if possible, okay? So, and then is another way, whenever you put the laser fiber in, the tip of the scope has to be straight, okay? So when it is deflected, don't put it, otherwise you are going to, I know that you know it. But supposing you are here, you are seeing the stone, you're straightening, your laser fiber is going out, and now you are trying to deflect. Now you are not reaching. What will you do? Possible, hai na? So usme, then sometimes there is a ball tip laser fiber which is available. So keep your scope deflected, look at the stone, insert the laser fiber with the tip deflected. It will go directly up to the stone. This is a ball tip laser fiber. That the ball remains only for first few minutes, 1 or 2 minutes maximum. Then that ball is gone. You understand? So next time when you want to use it, you are using it as a regular laser fiber. Don't use it as a ball tip. Otherwise, if you think that it's a ball tip laser fiber, let me introduce, then your scope is gone. So first go, most important, go in, break it into, or keep the laser fiber in and do whatever you want to do it till it comes out. The moment the laser fiber is out, it is a regular laser fiber. You can use it as a regular laser fiber, but you cannot use it as a ball tip laser fiber. Okay. So I think any questions now you have, see, this is under vision removal of the sheath. This sheet, okay. I'm just taking out. This is a
This is in a semi-rigid, no, sir, you're taking or the same flexi scope?
this is a digital scope. You can see that I'm taking out the ureteral access sheath under vision. So you have to completely see the lumen. So I'm out now. Almost.
Now we stand separately, sir, after
Yeah,
removing.
we can place a guide wire.
Look at the ureteric orifice now. You can see that. But in this case, because there is no safety guide wire, again you have to scope in and put a guide wire. Or you can again go in here up to here with this scope, put a guide wire from below and then take out the scope. Right? Okay. So I think you should try that thing, whether you are in a position to do that movement. And then let's see. No, it's not very rarely necessary. Yes. Indraneil, how are you?
Good, sir.
Good to see you, man.
I'm around, sir.
Ah, no problem. नहीं डिफ्लेक्ट करो, हाँ घुमाओ, अभी दूसरी तरफ घुमाओ, नहीं पकड़ो, डिफ्लेक्ट करो, ओके. नाउ जस्ट रिलैक्स, आप एकदम रिलैक्स हो जाइए. ओके. इसको ऊपर क्यों करते हो, नीचे रखो. ओके बस. और यहाँ से टाइट मत करो, यहाँ से रिलैक्स कर दो. आप बहुत टाइट रखते हो यहाँ पे. देखो, hold it here. I'm just holding it, okay. Okay, you can try this if you want. Scope को सही पकड़ो. Hold it here. Bend it. हाँ, अभी रोटेट करो. Excellent. Do it. Now bend it and go opposite. अभी भी कर सकते हो. करो करो करो. अरे देखो. And now you can deflect. You can go into the lower calyx also. ठीक है? आप करो. The same thing you can do it in the अब जो मॉडल है ना बाहर, वो मॉडल में भी आप करिएगा. तो आपको मालूम पड़ेगा कि बाहर है ना डॉक्टर, वो समझा देंगे आपको.
You will empty it with a syringe or you leave it, sir?
Just leave it. I just showed you this. I think probably you can see.
There is no need to withdraw that.
Just understand this. You can see a lot of dust coming out. I'm not doing anything. It is just simply evacuating during the procedure. It's done during the procedure. Okay. If you try to aspirate, there are some people are aspirating and they're putting on Twitter also. Right now, it is not recommended. Right now, it is not recommended. The reason is that when you aspirate, you are producing a negative suction effect, and that will damage some micro vessels in the mucosa. That can cause bleeding. The vision is totally gone. And RIRS vision is the key. If the vision is turbid, you are gone. And secondly, supposing you are aspirating, there is some fragment which is slightly bigger and which will block the accessory channel. What will you do? You are likely increasing the scope of damaging the scope. So at this moment, no. But in future, we must evacuate the kidney also. So make a very nice fragmentation, and there has to be some device like a vacuum ureteral access sheath or something like that, that will produce a very nice gradual aspiration of whatever content it has. So then you can on table that particular day only you can produce a complete clearance. Then that will be the best day for you RIRS. Comfortable हो? Sure, बताओ. देखो आपने कंपोनेंट समझ लिए 3-4 हैं. अब आपको हर एक पे जस्ट आप समझो कि डिफ्लेक्शन लीवर है. Do not produce too much of the pressure on the deflection arm. यहाँ पे कुछ लोग in order to enter into the lower calyx, supposing आप बाकी है ना आपका? हाँ, तो हाँ, done. अभी मेरे को थोड़ा रेस्ट लेना पड़ेगा. Continuously I am speaking for 2 hours. So नहीं लंच नहीं लेना है लेकिन मेरे को बैठना है थोड़ी देर. See, what was the question? Sorry, I forgot. Yeah, you aftercare. Okay. So too much. Supposing I am not reaching to the lower calyx. Now some people will put lot of pressure on this deflection lever. Just somehow they want to reach. Don't do it. You know, you have to be very gentle. You know, supposing if there is a limit up to here, I do not want to go to my maximum limit also. Okay, that is one thing. Deflection lever. Secondly, insertion of the laser fiber. If it is straight, it will not damage. How do you know that? One, the deflection lever has a neutral position, but after several use, it may not be correct guide. So watch it on CM. Okay, if it's straight or not. Most important, and I have always told my staff that whenever I am inserting the laser fiber, okay, tell the staff, my staff will only shout that, okay, sir, wait, straighten the tip. Because sometimes, you know, when you are doing a lot of procedures, sometimes you become overconfident also. So it's always a good idea that tell your staff, tip straight है कि नहीं, check कर लीजिए, तो वो कर लेंगे. दूसरा क्या idea है? Supposing now the problem with RIRS is that some people say that there is again slight risk of radiation exposure. PCNL में तो ज्यादा ही है. RIRS में कम कैसे? तो हम लोग क्या करते हैं? What I have done is to reduce the risk of radiation. अदरवाइज रेडिएशन कहाँ पे यूज होता है? आपने सिस्टोस्कोपी किया, आरजीपी किया फर्स्ट, और कहीं लोग तो बहुत ज्यादा करते हैं. दैट इज वन. सेकंडली डबल ल्यूमेन कैथेटर डाला, यूरोटल एक्सेस शीट डाला, उस टाइम पे हो गया. थर्ड अंदर गए, एंटायर पेल्विक एलाइसिस सिस्टम विजुअलाइज करने के लिए कुछ लोग करते हैं. एंड देन दे स्टडी द एंटायर पेल्विक एलाइसिस सिस्टम इनिशियल पार्ट में. कभी भी हुआ. चौथा, जब आपने जब प्रोसीजर खत्म हुआ तो सी कि भाई अरे सब स्टोन खत्म हो गए कि नहीं, तभी यूज कर लेते हैं. बराबर है. और चौथा डबल जिस्टेन डालते वक्त. पांचवा, तो ये 5-6 टाइम यूज करते. तो हमने क्या किया है अभी, देयर आर सम पेपर्स ऑन दिस आल्सो. So what I do is that first I do semi-rigid retroscopy, put a guide wire under vision, no radiation. When I'm inserting the ureteral access sheath, if the ureter is good, with my tactile feed only I go in. Don't do it in exam or when you are learning. Okay, but this is because I'm doing a lot of RIRS. I want to reduce my radiation risk also. So I simply just go in with my ureteral access sheath, and most of patients I use a new ureteral access sheath. So I will be in I just know that okay, I'm fine or I'm not fine. I'll just put it like this. That's second. Thirdly, I don't do dye study. So I finish the procedure, complete procedure. When we can assess all the visually see the, why do you need to do RGP to see whether if the stone is not found, we can do that. Okay, that is fine. And the last thing is that I do RGP in all patients post-operatively. Once the procedure is completely over, before putting a stent, I do RGP. Now people ask me why should you do it when you can see the double J stent lying in the upper calyx? You can directly backload your double J stent over the guide wire and finish the procedure. But I do it at this moment is because during the RIRS surgery, if I have taken little more time, say for example, 50 minutes, 60 minutes, 90 minutes sometimes, in that case, I want to see whether I have caused some intravasation or extravasation. So many times you don't realize it when you are doing the procedure. And then when you see finish the procedure, there is a lot of intravasation or extravasation. So this is the case where I would like to put a double J stent and retain the double J stent for a little longer time. So because my fluid is flushed by my assistant. So how much pressure he has put, I don't know. So sometimes it can create a problem. That's the only where I am using a radiation now. I'm not using radiation for an entire procedure. But if, of course, ureteral access is not going easily, I'll wait and check. Okay. But even if while putting a ureteral access sheath, if you are using a C-arm, it is fine, no problem. Because then the maximum time we have noted in last few cases is our radiation is 6 seconds. So we give 6 shots maximum. All these steps only 1 shot, even if I'm using it completely. Otherwise, if I'm using a last shot, only 2 seconds. So that is nothing. Yes.
Group 3 and 4.
So I hope you guys had enough experience. Okay. चलो कुछ भी काम है तो बताना. हाँ कोई भी problem नहीं. चलो. Please ले लो ना.
3 and 4, please go to Crown Plaza for robotic session.
Oh, sorry, sir.
3 and 4. Yes, 3 and 4. 600.
ये माइक लगाना है, ये रिसेक्शन विल गेट स्ट्रीम्ड.
Asian Institute of Nephrology and Urology. ఎక్కడ కాదు హైదరాబాద్ ఎక్కడ
ఇప్పుడు ఎన్ఆర్ఐలో ఉంది. అదే అంటే మా దగ్గర ల్యాబ్ ఏం లేదు సార్, మనకి పోస్ట్ ఎంసీహెచ్ ఉన్నది సార్, అంటే ల్యాబ్ తీసుకోవడం
ట్రైనింగ్ ప్రోగ్రామ్స్ ఉన్నాయి.
ఎక్కడ సార్ మన ఏం లేదు అంటే ఎంత డ్యూరేషన్?
డిపెండ్స్ ఆన్ హౌ యూ
Why is very helpful?
You have to teach now. Now that you have learned, you have to teach. Come on to this side, they want to record it. All of you are from RMN? Uh-huh.
I am from Kolkata.
Okay.
I am working with Park Hospital, sir. Gurgaon, Palam.
In Jodhpur. Vijay Madhuri and Vijay is with us now.
Yes.
So, good. So, who all are doing laparoscopy? Who all have been assisting laparoscopy? Who all are just watching laparoscopy? Doing what all you do? Okay, good. Nice. How about others? Nice. So, with that background, many people do somehow finish up the procedure. That is what my intention is, to go in a methodical way so that you learn the proper steps, put it in a proper perspective, do it with comfort so that you can do more number of procedures with less discomfort, with a good ergonomic. That is what my intention of taking you today through is, and knowing about your equipment as to how to utilize it in a proper way. Only when we know about our equipment, we can utilize it in a proper way. If we don't know where the gear and the clutch and the brake of the car is, where it needs to be pressed, you will not press, and where it not supposed to be pressed, there you press and you'll have an accident. That's how it happens. So knowing your equipment is equally important. Knowing ergonomically how to place yourself is also important. If you are driving in a crooked position, you will not drive for long. You will get exhausted, you will stop. When only when you are comfortable sitting in a nice position, you can drive for a longer distance. So laparoscopy is also something like that, because there's a lot of things involved here. Ergonomics is involved, technical aspects of the instrument are involved, and know-how about the equipment is involved. You'll have to know all this before you venture into doing any procedure. By some hook or crook, doing a procedure is not an important thing. Fine. So one good advantage of laparoscopy in urology is you will have only two positions. One is a flank position for the kidney or any upper tract reconstruction or any upper tract extirpative surgery like a nephrectomy, a pyeloplasty, a partial nephrectomy, or ureterocalicostomy, ureteropylostomy, adrenalectomy. All these are upper tract, things where you can have the flank position. Anything in the pelvis, VVF repair, ureteric reimplantation, laparoscopic radical prostatectomy, laparoscopic radical cystectomy, all these things are all pelvic surgeries. So these two positions of port placement, of access into the abdomen, and proper ergonomics for these two positions, you will have to know. Only then you will have to venture in doing these procedures so that you can last it for long. Otherwise, what you do is you tell you will do a nephrectomy, but in your mind you will say, "Abba, nephrectomy open rehta to acha tha." That should not happen. I'm struggling, I'm somehow doing, I've done nephrectomy, but that satisfaction of doing it comfortably will not be there. That should be there. You should, at the end of the procedure, feel that you are not exhausted. That's more important in doing any procedure. For that, some few basics you'll have to learn as to how to go about. Okay? So you use varies or open technique? What do you generally follow? All are varies only. Okay. So where do you plan to put a varies needle in a flank position? Fine umbilical line. Correct. When you put a varies, what all things you check whether you have gone into the proper peritoneal cavity or not? Next step is varies. Varies means what next you will have to do?
We'll push the saline,
Mhm.
then we'll aspirate.
First you push the saline, then you aspirate.
First we'll aspirate.
First you
then
aspirate.
push the saline,
Why?
then we aspirate.
Why? First you aspirate. Why?
First we'll need to check whether it is in bowel or not. We'll aspirate. If it is in bowel or in vessel, then blood will come.
Blood will.
Then we'll push the saline. Then we'll re-aspirate. If it is not coming, that means it is in peritoneal cavity, not in pre-peritoneal space.
See, there are two basic tests that has been described as putting a varies needle. One is the aspiration test. Just to aspirate and see where you are. You will know the contents of the cavity. Either it's a cavity in an IVC or a major vessel or intestine or a peritoneal cavity. You'll get blood or bubbles. Then this hanging drop test. You put a drop of saline and lift the abdomen gently so that it creates a negative pressure, and that drop of saline gets sucked into the peritoneal cavity. That is to know whether you are there in a cavity or you are there in a preperitoneal or a retroperitoneal space. In those spaces, you will not get this suction effect. Peritoneal cavity is a negative pressure cavity. So whenever you put a drop of saline and lift the abdomen gently, that gets aspirated inside. That is one way to know ascertain whether you are there in a bowel or a vessel or a cavity. That cavity can be a preperitoneal cavity, retroperitoneal cavity, correct, or an intraperitoneal cavity. So which cavity you are can be best ascertained by an insufflator test. To know that what is exactly the insufflator, you should know what insufflator does. Fine. Then I will tell you how to put a varus, where to put a varus, and how to plan a port. How do you plan a port? Last time I have been telling, one thing you learned today is shabash. Last time it was useful, then coming all the way. How many of you mark before you insufflate? Mark all the ports, 4 centimeters here, 4 centimeters here, this way, that way, this spine umbilical line, anticipatory spine. 2 finger width above the umbilicus, everything is marked. Then you put a varus needle and insufflate. Happy birthday. A balloon with a happy birthday printed on it will be so near when it is not insufflated. When you insufflate, what will happen? This will go this way, this will go this way. So your marking which are there before insufflation will go away from each other when you insufflate. If it is a Paris lady who has delivered 2-3 babies normally, he will have a huge capacity. He will have a capacity of 3.5 liters of carbon dioxide that can go inside the abdomen. If it is a young, thin fellow, athletic fellow, 1.5 liter, it will stop flowing because his capacity is not so much. So every patient's abdomen behaves in a different way. So whenever you mark a point of ports on the abdomen to do a surgery, it should be after insufflation. One thing if you can carry today after attending everything is marking a port. See, he has remembered very nicely. Marking a port only after insufflation. Clear? Many textbooks, everything, everywhere they describe so many fingerwaves from there, 2 fingerwaves above the umbilicus. Fine, they are good at their own point because that is a natural average. They take average. What is the average weight of an Indian? There is a 60 kg. But nobody is 60. Everybody is 100, 120s. Almost double of what the averages are. So every abdomen is different, and every umbilicus to the external distance is different. Umbilicus to pubic symphysis distance is different. So every abdomen behaves in a different way. So marking for a port placement should be done after insufflation. Clear? So coming to the insufflator. Have you ever wondered how this insufflator works? What are all the readings? What are all there? Imaging, light source camera, there is no much of a thing that you need to learn about it because everything is already set up. And you need not know these readings on these things to know anything much inside the peritoneal cavity. But an insufflator you need to know because that will give you confidence of entering the proper cavity of insufflation. Okay. So any insufflator will have a pressure reading, a flow reading, and a volume reading, and a cylinder which shows whether that is full or empty. Few extra readings like which cavity you want to use, a normal small baby or a normal adult, or a smoke evacuation mechanism which few insufflators have. But these things are common in any insufflator: pressure, volume, and flow rate. So these three things you will have to be very confident to know whether your varus is there in the proper cavity or not. Okay. You ever wondered how it works? Any idea? Anyone? Have you seen any time how the flow of the carbon dioxide happens through this? How does it happen?
The flow, the increase in the flow.
Hmm?
If it is in the abdominal cavity, then it will slowly rise.
Hmm?
And if it is outside or the momentum is at the
No, those are the readings here. How does the flow happen? Flow happens in a pulsatile way. It is never continuous. It is never like ऐसा नहीं रहता कभी. It is always why like that? The entire column of carbon dioxide till it is connected to the varus is there. That column is there. So whenever it is flowing, it is distending the cavity. Whenever it is not flowing, it pauses for a second. When it pauses, That pressure inside the cavity is again measured by the manometer which is there inside. So that is how it gives the pressure here. In the pressure reading also there are two things. One is the set pressure or the desired pressure that we have set here. We want it to be reaching 16 and only then stop. This is the actual pressure. That is what exactly is the pressure inside the abdomen, which is measured when its intermittent flow is happening. We want this pressure to be equalized to this pressure. That means we want the abdominal cavity to reach a pressure of 16. Only then the flow stops. Fine. This is the so many liters per minute flow rate, a rate at which the carbon dioxide is coming out through this tube going into the abdomen. That is the flow rate. So many liters per minute. What is the normal flow rate of this insufflator? Any idea? What is normally used in laparoscopic urology? 2. Varix needle accommodates not more than 1.5 to 2 liters per minute. But these insufflators which we use in laparoscopy, for urological laparoscopy especially, are 40 liters per minute. This is a high flow insufflator. How do you know that? So this is a low flow rate or a Varix flow rate, which is 1 liter per minute. Then is a medium, then is a high. Here it is showing 30, but actually it is a 40 liters per minute flow rate of a high flow insufflator that are available. Why 40 only? Why not 60? Why we require a 40 liters per minute flow rate? Because when you suck, suppose you are doing a XGP or an infected kidney, hydronephrotic kidney, or you are doing a case where there is a psoas abscess, you suck a lot. There is so much of bleeding. You are doing a partial nephrectomy. There is an accessory vessel that you have not ligated or you have not applied bulldog. It is bleeding. You have to suck. You are using a 5 mm suction continuously on that. If you continuously using, the abdomen collapses. So the flow should be so much that even if you are doing a continuous 5 mm suction, the abdomen should not collapse. That is the reason it is 40 liters per minute flow. Clear? If it is doing in a pediatric case, you don't require so much of flow. So low flow insufflators are 15 to 20 liters flow insufflators. These are advanced high flow insufflators of 40 liters per minute. Clear? Then comes the volume. So many liters, see, just L. So many liters have already gone in. This shows the total consumption of carbon dioxide that has gone inside the abdomen. Why is this important?
When they put various and this much amount of
That is one thing. Second thing, suppose your ports are all leaking. Then you'll have a continuous flow and you will know how many liters of carbon dioxide has already gone through. Suppose you have done an open Hudson's technique of port placement and you have made a big incision. Continuously gas is leaking from there. You will have continuous flow. You will have some 500, 600 liters of carbon dioxide that has gone in. Clear? So all these things are equally important. So what will happen if it leaks? Let it leak. It is flowing nicely, no? Let it leak. What will happen? Continuous leak over a period of 2 to 3 hours of big surgery causes a lot of changes. There are physiological changes that will happen. You don't want those things to happen. What will happen? When you drink a tea or a coffee, you put it in a saucer. Why do you put that? No, to increase the surface area. When you have a tea or a coffee, you put it in a to decrease the temperature of the tea or a coffee, to increase the surface area. Big plate, you put the more surface area, it will dissipate the heat more fast. You have to flight or a train. What do? You blow also. Why? You want to make it cooler faster by convection. You blow also. That convection air itself will decrease the temperature more fast. What is this doing if your port is leaking? It is blowing continuously inside the abdomen. Continuously it is blowing. What will happen? Patient will develop core hypothermia. You're blowing air inside the peritoneal cavity. So core temperature of the patient goes down. Coagulation defects happen. Patient goes into arrhythmias. If it's a prolonged procedure, all these things happen. That's why your ports should not be leaking. Your flow should be static. Your inflow and total liters should be physiological. It shouldn't be non-physiological. Supernatural things should not happen. That is the reason all these readings are there. So many things are there in an insufflator, we never knew. Okay. Now coming to few scenarios as to know where your varus needle has gone in. Simple things, by seeing the insufflator, you will know where your needle is. The aspiration test and hanging drop test are equally important, but those are initially for the entry of the varus. Once entered, whether you are there in the cavity or not, this is the best possible test. They have compared, their studies which compared this to so many other tests, but they have shown that insufflator test is the best possible test to know whether you are there in a proper peritoneal cavity or not. Suppose you are there in a preperitoneal cavity. Your desired pressure will reach very fast. Your flow 1 to 1.5 liters would have happened, but the entire flow should have happened only 200-300 ml, because your preperitoneal space will not be a huge space to accommodate liters and liters. It will have a note compartments. You have a space of radius, you have space of colis fascia, you have got facial attached here, so it will not be continuously flowing everywhere. It will have a defined space, it will stop. So 200-300 ml of carbon dioxide has flown, your pressure has equalized and flow is not happening, means you are in a cavity which is very small, preperitoneal space. You will get a crackling sound. Clear? So suppose you are having a pressure which is low or minus 1, 2, 3 like this. Flow is happening at 1 to 1.5 liters, which is the maximum flow through a varus, and the volume has gone more than 2 to 3 liters. Still it is flowing. That means you are in a cavity that is continuously emptying. Which is that cavity? You are gone in a IVC. Because it is aspirating continuously, it's a negative pressure, your volume is still flowing. The pressure is not increasing because it's an IVC, it's going intravascular. But why we are not knowing? That is because varus needle doesn't cause embolism. For air embolism, 1 to 1.5 liters of air will not cause any embolism immediately. Patient will develop arrhythmias, ETCO2. ETCO2 will rapidly increase on the monitor. Those things have to be taken care of. You should see arrhythmia. The ECG has to be watched and this thing has to be watched. But initially in the aspiration test, you would have got blood. If you forgot to do aspiration, this is what happens. The next checkpoint, you will find it here that these all things will happen. Many other hypothetical situations are there. Suppose you have gone in a transverse colon. Then even the pressure equalizes fast. Your flow is happening at a minimal level and only 1 liter has gone. And entire abdomen has not distended uniformly. Only a particular quadrant of abdomen has distended. That means it has gone into a transverse colon or a bowel loop, where it has distended that particular bowel loop to a particular extent and it's not flowing beyond that. So it has stopped. Clear? So these are the things which we know so much just by looking at these readings on an insufflator. That's why it's such an important thing. Light source and camera, you should be aware, but need not bother much. There are different types of insufflator, there are different types of light sources. Best possible light source is the xenon one. Now LED is a cold light source. It will not be hot. It doesn't increase the temperature. Neither it causes burns. Fine. That is an LED light source. Then processor, again there are different types of processors. You can have a single chip camera head. You can have a 3-chip camera head. You can have a CMOS sensor or a CCD sensor. So it depends on what you are planning to do. If you're doing endourology only, you need not go for all these 3 chips and all that. You can have a single chip CCD or a single chip CMOS sensor. That should be more than enough for endourology. If you are planning to do high-end laparoscopy, 3-chip CCD or a 3-chip CMOS is what is required. Because why 3-chip? It will have 3 different sensors, like how we have a camera. Why do we have so many sensors on the camera? These are different charge coupled devices. So whenever light falls on it, it gives a level of amperage or current that is generated. That is calculated by the processor to give an image. Fine. So more the number of chips that do that, better the resolution of the image. So 3 different chips for 3 different colors, R, G, B, red, green, and blue. You will get a better resolution, better color reproduction. Fine. So basically, if you want to do a high-end urological laparoscopy, go for a 3-chip CCD or a 3-chip CMOS camera. CMOS is a newer generation of those camera sensors. Fine. This is about the light source, camera, processor, and insufflator. Clear? Any doubts? how you are putting a varies, how are you reading the varies on the insufflator. Clear? And the most important point, mark the ports only after insufflation. ठीक है ना यहाँ तक? So how do you mark now? Only two positions that we are most important. One is the flank position, one is the pelvic position. For flank position, where you will mark? Give me your book. No? No, give me the book. ना इसके अंदर बुक है देखो. Suppose this is the head end of the patient, this is the leg end of the patient, this is the costal margin, this is the cisterna, this is the umbilicus, this is the inguinal ligament, anterosuperior iliac spine. This is the right sided kidney, here surgery or planning. Let it be pyeloplasty, let it be a renal tumor, let it be a radical nephrectomy. You will have to, this is your target organ. How do you plan ports for this? You have already put a varus needle here, insufflated the abdomen. Where you will put the ports? Well, you will mark the ports first.
First camera port along with tip of the 12th rib.
Again, tip of the 12th rib will be here for me, here for you. Until absent 12th rib for someone. How will you mark?
After insufflation, tip of 12th rib means more or less hilum will be there. The vein will go inside. But I have been taught, sir.
That's right. I want to learn that first.
So I've been taught that whenever we are going inside, more or less the hilum will be near the 12th rib tip.
Okay.
So we just little bit of practice. We just put our first camera port here. And after putting camera port, then if there is no any abnormality or any means after going inside, we are not finding anything.
No adhesion, nothing.
No adhesions. Then just we put our one of our port just below the Ziffy sternum, slight laterally, and one port that finger breadth away, 4 fingers breadth away, in the mid
clavicular line. Person is Yokozuna, a heavyweight champion. His abdomen will be like one big balloon. Where will his diphisternum be? Where will your 4 fingers, small 4 fingers be on his abdomen? Nowhere. Fine. So always plan your ports after insufflation such that they form a angle of 60 degrees at your target organ. This is your target organ. You have to do majority of the work here only. All hilar dissection, everything happens here. So this instrument should form a 60-degree angle here. Suppose the 60 kidney is here, very high up kidney. This forms here, but you cannot put a port transthoracic. So you'll have to put a port here only. So your first port is fixed below the costal margin on a line that is extending and forming a 60-degree angle with both of your arms. Clear? Any doubt? To give an example, same patient, head end, leg end, kidney here. This is the costal margin. You cannot go above the costal margin and do like this. The costal margin is fixed and you have to form a 60-degree angle here at the organ of interest. So anywhere on this line you put a port on the abdomen. This you cannot go above. This is fixed. Got it? So another instrument will make a 60-degree angle here. You can make like this also, no? So this should form 60 degrees. And how are these forming 60 degrees? With your arms at rest from adducted, this angle 90 degrees or above, beyond 90 degrees. This should be the position. These are it should not be like this. You can form 60 degrees like this also. You can form 60 degrees like this also. Then your ports go more lateral. But you should be comfortable from the arms by the side. Angle at the elbow should be 90 degrees or above. And these two instruments should form 60-degree angle with each other. at the target organ and go up till you reach the costal margin. That is the uppermost extent. You cannot go beyond that. So that will form the first port. Clear? So once this is on the form, we put a camera through that and see and under vision put the rest of the ports. Where do the rest of the ports come from? You put this first port, you are seeing from here. So this 60-degree angle, one more port will come, and between these two, camera port will come here. Anywhere in this line from here to here, you can put. Clear? Any doubts? Acha. 60-degree angle can form, and you can put a port here also, here also, here also, here also, here also. Why you put it here only? Rhomboid is forming anyway. See, you can form a rhomboid. You can form a rhomboid like this. You can form a rhomboid like this. This is also forming 60-degree. Where on this line you will put these two ports? Half of your instrument should be inside, half of the instrument should be outside. That point has to be marked, and that is where you put a port. Why half? If you have a fulcrum here, more movement outside will cause less movement inside. If you have a fulcrum here, you are away from the target organ. Suppose the kidney is here. Suppose the kidney is here. You are putting a port away. Mera nazdik chahiye. The fistona move 3 fingers from the fistona. You put it here. You move here less. You will be moving there very much. Only when you have the fulcrum in the center, whatever movements you do, nicely will be reflected there at the tip of the instrument. So, again revising, 60-degree angle, target organ, costal margin is defined, you cannot go beyond costal margin. 60-degree angle, your arms are by the side, angle is above 90 degrees. And in this line, where do you put a port? Midpoint between the half the distance of their instrument. At this point, you will put one port. At this point, you will put one more port. Camera in between anywhere, whichever is convenient. Clear?
Gauge the of the port is inside the
That's what you imagine your kidney here, no? You know where your kidney is on CT. How far the kidney is? It is in the thorax, very high inserted kidney, or it is there halfway below and above. You know where it is. And your costal margin is defined. That cannot go up. So your right hand port is defined. Halfway inside, outside, you can see no on the surface. If you put also, this much is inside, this much is outside. And these instruments are how long? These are 30 to 33 centimeters. So 15 centimeters, 15 centimeters. This span is generally 15 centimeters. So 15 centimeters should be the fulcrum. This is for kidney surgeries or for upper tract, pyeloplasty, anything. Suppose the same thing you're doing for pelvic surgery. You're doing a VVF, you're doing a reimplantation, you're doing a radical prostate or radical cystectomy. This is how it's going to be. Again, same 60 degrees. With your arms by the side. Here it is not an ergonomical position because the table is high up. For my right hand, I am lifting my right hand. I will not be able to do the surgery more than half an hour. My hand will start aching, I will stop. So, either take the table down or you go up and be comfortable. Like this, I can do hours, 10 hours also I can do. Got it? Same thing, 60 degrees at the target organ. Your arms by the side, angle more than 90 degree at the elbow, comfortable. Everything in one line. Your target organ, yourself and monitor. Monitor should be here, not there. If you are doing it like this, seeing there, your ergonomic is lost. Because you are tuned not to see like this and do like this. If you are driving car by seeing from the window, will you be able to drive? No. Ergonomically wrong. If you are able to eat from your plate by seeing somebody else's plate, will you be able to eat? No. You should always have an image, your target organ and yourself in the same line. Then only your movements will get replicated properly on the monitor. So 60 degrees, halfway port. 60 degrees, arms by the side, comfortable, halfway port. So these two ports for a pelvic surgery. Comfortably, you do half an hour also, nothing will happen. Done? These are port markings for port placement for pelvic surgery and upper tract surgery. Clear? Now coming to, this is a left-handed needle holder. Your curvature should be towards you. Don't use this for your right-handed people. Next comes to doing this suturing, doing the manipulation. Somebody can hold the scope for me. You tend to stand on the right. That is wrong. You will come on to the left. You will obstruct my right-handed movement, which is my dominant hand. So always be on the left hand of the surgeon who is a dominant right hand fellow. I'll be doing more of my movement on the right hand. Left hand I'll just support. And you should be standing behind me. If you stand in front of me, my left hand movement will be obstructed. You put your right hand in between my, yeah, see? Ergonomically such simple thing, but comfortable. Next thing is, suppose your ports are all ergonomically placed, everything is fine. Actually, it is not fine now, but what you should practice is holding the needle in whatever direction you are holding. See to it that you hold the thread, align it in a perpendicular direction to your right hand, then hold it in the center. Then when you take a bite, it will go in directly. Alignment with your left hand and the right hand is equally important. Use a left hand instrument, loosely gripped instrument on the left hand like a Maryland. Hold the thread to change the direction of the needle. Hold it in the center of it. Then take a bite. Clear? Show below. If suppose the needle is directed in a different direction, hold the thread, put it up and get it into your alignment. Or with the needle holder itself, take it and direct it in a way that it is perpendicular to the needle holder, this needle, center of the needle. So that when you hold it, you should not be thrusting the needle holder in the tissue. You should be rotating your hand for it to pass through. Suppose I have held it like this. I shouldn't be moving my hand left and right. It should be like this. Suppose it is there. It should be rotatory movement. See, only rotation. There is no thrusting. You will know where the needle comes out because you know the curvature angle of the needle. You will know where it is coming out. Halfway come through. Again, no pulling. It should be rotating only. Then it will not tear the tissues. Only rotation. Clear? Once you have taken a bite, once you have aligned the needle, next thing is knotting. For knotting, always have a seal loop. This loop can be in any direction, but it has to be brought into this direction. This is the way the seal loop has to be. It should come onto the side of the needle holder. It shouldn't be in the air. It shouldn't be. It can be here also, no? But it should be brought here. And this thread should not be much. Keep it at as short as possible. Then get this loop onto one side. After you have got it, see my movements inside out only. Left hand is moving inside out only. Fine. This movement has to be. Get the needle aligned again. This movement only. This is a forward throw. This is a backward throw. This is a forward throw. This is a backward throw. This movement has to be done and learned at least 15-20 hours. Not 15-20 times, 15-20 hours. Show me down. This is how you're supposed to do. There are few movements in laparoscopy that are intuitive and counterintuitive. What is intuitive movement? You move inside, everything is moving inside. You come outside, everything is moving outside. Fine. You're rotating medially, it is rotating medially. You're rotating laterally, it is rotating laterally. These are intuitive movements, but that means what you're doing outside are reflecting inside. If you are counterintuitive, that means you're moving up, it's going down. You're moving down, it's going up. These are ulta movements. These are counterintuitive movements. Fine. You're going medially, it's going laterally. You're going laterally, it's going medially. So these are all ulta movements. So you have to balance between intuitive and counterintuitive movements. You have to increase your intuitive movements, decrease your counterintuitive movements. Then you will do laparoscopy comfortably. See, all my movements are inside out only. See? Getting it? This is back and throw. This is forward throw. This is back and throw. This is a forward throw. Practices hours together. Okay? Anything, any doubts, please let me know. But to do this, the rest all things should be aligned. That's more important. Doing this is not important. Having a proper knowledge of the insufflator, having a proper pneumoperitoneum, proper port placement before you do any venturing of surgery. The rest all is dissection, rest all is manipulating your instrument, how to take a knot, how to take a bite. Rest all is just that. That you have been doing in open surgery for ages. But ergonomics is the one thing you miss. You follow some supernatural dimensions and end up in struggling. That should not happen. It is a struggle which stops you from doing rather than the procedure itself. If you are properly positioned everything, you will do it in a very nice way, in the shortest possible time. One can hold the camera, one can start doing.
उधर सामने करते रहेंगे उधर तो हम लोग। ये थोड़ी सी है।
हाँ ये अच्छी है, ट्रॉली स्मूथ है
स्मूथ है, पत्थर तक की है।
और सही है, मतलब इसके सस्पेंशन भी अच्छे हैं। यार एक टूर करते हैं यार साथ में।
कहाँ किस तरह लगाएगा? इधर किस तरह मूव होगा सब? ऐसे होगा ना?
हाँ
इसमें अच्छा अपन ने पहले ये सिलेक्ट किया था ना, ये वाला था ना ब्लैक मैजिक ऊपर for microphone we need to assign to Realtek or black magic.
Black magic. No, I think it's working.
Working?
Yeah. No, just turn on again. Turn off everything.
Turn off.
Turn on, please.
Space completely vacant. Finally, all of you? Yes. Ready? In the last batch also? After exam? That is fellowship entrance exam. Okay. So, in PCNN, in PCNN, no. So, next year. So, basically is to train guys to know things of any surgery, for example, puncture in PCNN here, before you actually go on to the patient and write out on the patient. Exercises today we are going to do 3 exercises because of the constraint of time. So now we have a hollow box kind of a simulator, which you need to imagine this is the foot end of the patient and this is the head end of the patient. So see here is a solid pelvic calcium system with 6 calluses, the calluses which are lower, middle and lateral, which are the upper ones. Okay. This is the posterior side. And, so the green ones that we see here are the posterior calluses, which we want to puncture usually. Which are not punctured, they are the anterior ones. Lateral calluses, we usually like lateral one. Exercise that we are going to do is to learn calyx by serum. See the serum picture, exact position replicated. So this is the head end, here we have the head end. This is the foot end, here we have the foot end. Side here, and the lateral side here. So it's always better that you have a similar way start off with PCNS. So you just take this picture and try to replicate it. And trying. Now let us see how we can identify which is anterior, which is posterior. Now all of us know that the green one, if you look at the screen, the green one, that is this calyx is the posterior calyx. and it is sort of end on. So when we move our CM from 0 to 30 degrees, keep on looking at the screen. I would like to describe the movement that is seen between the red and the green carrots. So initially brown and red were on top of each other. The green went from 0 to 30. What is happening? So now you can see the anterior is more lateral than the posterior. Let us go from 30 degrees back to 0 degrees. Lenses are not moving. Only the CM is moving or the camera is moving here. Okay? When the CM goes backwards, the posterior calyx has come laterally. Let us move the CM cranially and see what happens. So the CM goes cranially. The posterior calyx is doing caudally. So CM goes caudally, what should happen? Direction in which the CM is moving supposed to be moving in the opposite direction. And the same still here. So let's cover the simulator. Sorry. So now we have this black and white picture, and I would like you to recognize which is the anterior calyx and which is the posterior calyx. Which is in the front. So it looks like a globular thing, but we are not sure which is what. So let us go from 0 degrees. So see, they have to see this also and the screen also. So then both of you can come this side. To show the simulator also and the screen also. So now let us make see what happens there. And which is the posterior calyx? Okay, correct? Any decision here? Yes. Calyx. So now direction the CM goes in, the posterior calyx would be that this by looking at the pelvic calycial system when it was open on the simulator. And the same knowledge we applied on a black and white picture, and we found out which is anterior and which is posterior. Okay. So this was the first exercise to be able to determine which is the posterior and the anterior. Now, here the infundibula are long, that was not there, so that you can appreciate what is anterior and what is posterior. But on the actual patient, the infundibula may be short, and it may be little tricky to appreciate. On the magnification in the CM, then definitely it's quite easy to appreciate. The infundibula are so small that it is sort of a complex or a globular kind of a complex. And you need not identify what is anterior because you get spherical complex posterior calyx was superficial, hence it was moving. But if I have another radial object on top of the posterior calyx, the posterior calyx also. We will see that when we do it with the needle. So this is a sign which actually helps us to tell us also where is your needle tip as to the pelvic system. Or so if you are even superficial to the posterior calyx also, even superficial to the posterior calyx, then see how from 0 to more variable. So it would be set. What be the video which was posted on the group? Definitely. So what is the first step in the set technique? Start. This at the area where it is. So you can help me. So this side so that they can see the puncture. So this is the posterior calyx, right? We all are going to look at the screen now. We are not going to look. So once you are at 30 degrees, you mark calyx. So in this technique, skin incision is Siam. So the Siam has told us where to puncture because we okay. Then if you see now the calyx, the skin puncture and the Siam. To this point, with Siam, which is one line. If I take this needle into that line and push it in, it should ideally hit the calyx. So this needle into a point here. So the actual axis. If you feel there's a difficulty here getting the needle, you spirals of the needle. Support it always with the left hand because the body tends to sway as the needle of it. So support the left hand always. I'm doing it on a patient. Now once this direction is fixed, I need to know how deep to go. So I'm trying to be deep and superficial. But you cannot appreciate how deep I am, how superficial I'm coming out. See? So for that I need to go back to 0 degrees. So once I go back to 0 degrees, go to 0. Now here you can appreciate these deep and superficial movements. See? So now I will approach the calyx in 0 degrees till I touch the calyx, which will be demarcated. So you are in 30 degrees and see the depth or perceive the depth is 0 degrees. Shift yourself from 30 degrees to 0 degrees. It is very important to change the direction of the needle. Changes, do. So I want each of you to take turns doing this. So one of you can go on the CM. This CM you shift to the puncture, the next person can come to the CM. So by the time somebody is puncturing, the other one is already observed. You have to start with 0. Yes, from 0 to 30 you will decide which calyx. 30 you mark the skin point. First step is 0 degrees. First it is 0 degrees. Start the posterior calyx. And select. So 0 degrees you don't select anything. 0 to 30 degrees you identify the posterior calyx. Select the skin posterior. Stop. An exercise actually before. We are doing correct exercise. So only 0 to 30 degrees we are doing in order to identify the posterior calyx. Start. This one. Would be a full of the try to figure out how to use that. So puncture and the foot are maybe that axis. Sometimes but also there are various ways of identifying the so if it is a dilated system, the contrast is that. The pelvic system is narrow. So you just a little maybe one CCR float to a float. Sometimes this is pertaining to the posterior canals. Superior. Is it alright to inject it? Would it? But how will you be sure that your hair is not going? So that is my question basically. How to understand that? So see if see you are going into the medial canal. I am going into the medial canal. How do I ensure that the air will second thing is why do I need air for the superior calyx? Because superior calyx is non-natural kind of a calyx. You want air where you want to define different calyces which are superimposing on each other. So the concept of air stays only for this. Middle and below. Now hold on. If you want to see where you are now, you just choose this. See, you are very superficial. Supposed to be this direction. So, 30. There's no baseline. There's no define the direction in shut up. Briefly met in residence, sir. Sorry? We briefly met in residence, sir. Extensions, short segment verbal extensions. And then transaction. Welcome. Something else after I somebody check those QR codes that I gave. So this is what happens every time. See my depth. Yeah. So you need to get a digit and keep it in the push inside before so that the needle stabilizes. Before and visualize. To be covered before and visualize. Change to 0. Just gave the human just for yeah. So this here. Skip this here. Skip this here. Radiation exposure for the transformation. This is good. Which one? The favorite. That might be one of the files that you have launched. Now you don't have yeah. So, this is soft copy bit, huh? This is on your work around the group. Sure. Sure. Still with me. Somewhere. So, the PDF. So, make a copy so it should allow it's open source. That's just a Maybe that's maybe because my driver also like it. So you lock it. My driver. So this is my. She's already watching your time. So please, yeah, I share the link level with maybe down the PDF. Screenshots then whatever. Yes, share the link. I have shared this link. Send a screenshot. So all the so tell me, then I teach you. अभी टेप किसके पास थे? This is a recipe which we want to simulate. Tape so something. Then come from this next electron and you can pull out. What it is to identify your caption, which is easy and in a video. Same way. out on the CM. If you see, I'm trying to take my needle deep, but I cannot figure out how deep to go, whether this is the angle, this is the angle, this is the angle. So basically what is happening is I'm moving the needle in this plane. If you appreciate, this is the plane in which I'm moving the needle, and which this plane cannot be seen. If you see this plane as a line. So how do I observe the movement from this plane? I want to take this CM to a non-zero degree or a 30 degrees. So if you can help me, yeah. See, now from here you can appreciate the angle of inclination. Getting it? So in order to see this plane and the movement of this plane, I 30 degrees. And that's what I'm doing. So I'm going to have the adjustment. No, this is the posture calyx. 0. So I'll aim toward the posture calyx. Then is this plane. 30 degrees, please. Stop. Here, I'll use the same vertical plane, the angle of inclination, so that my needle is pointing towards the calyx. 0 degrees. That 0 degrees also, my needle is pointing towards the calyx. So it is pointing towards the calyx. Come fast, come quick. So much, so I'll go. 0. Faster, faster. Keep on shuttling between 0, 50, advancing 0 till I touch the calyx. See, little more to go. Sometimes what happens is I aim here in 0 degrees, then come to 50, vertical like this. I'm aligned, okay, my direction is correct. When I come to 0 degree again, see my needle, I have drifted away in the horizontal axis. So once I'm here, I know the angle of inclination is correct, I'll adjust the needle this way, so that my needle again is pointing towards the calyx. I'll not let the needle dip down, I'll not change the angle of inclination. Okay, so here you make this horizontal plane, the incline above is 30 degrees, when you come back to 0 again, you think you have made a mistake, then you adjust the horizontal plane here. Basically, the horizontal plane which was here has been lifted up by the angle of inclination, if you are trying to understand what I'm trying to say. Okay? Now, imagine a line going from the calyx through the skin and upwards into the sky. Then it will pass through the skin here. Let us call this point A. This is point B, and the C or the calyx is point C. Fine. Now, if somebody can give me a pen. So, if we try to do a cross section, this is the calyx. This is the vertical line going upwards, which is point A, which we have marked here, point A. See here, if you draw this triangle, it's out to be a sort of right angle. CM being rotated by 50 degrees, this would be 30 degrees. Basically, is a 30, 60, 90 degree angle. It passes along the hypotenuse here. It is, and you use a sort of 0 30 jump. It's called the triangulation technique. So if this is the skin point A, have you got this? So it's basically this line going upwards. This is point A. Like a puncture. This is the calyx inside. So it's in this the same calyx approached in bullseye as well as triangulation is going to have different feature points of the skin. Understood? Is it?